Okay, we are live.
Good morning, ladies and gentlemen. I'm Dr. Sai Kumar. I'm president of the Cochin Ophthalmic Club. A very warm welcome to all the speakers, the panelists, and the delegates for the second session of the Worldwide Ophthalmology Revision 2021. The first session was yesterday evening on cataract, and so this is the second session that is going live. We have a very wonderful panel here, top glaucoma specialists from across the country and across the globe, led by Dr. Ronnie George and Dr. Aditya Niog. They will be basically chairing the session along with Dr. Abhilash and Dr. Manoj from Cochin. So I'm sure you're going to have a wonderful 3 to 3.5 hours of glaucoma learning today morning. Welcome once again. I request the Cochin Ophthalmic Club Secretary, Dr. Gopal, to introduce the chairpersons, and they will take over from there now. Dr. Gopal, please.
Thank you very much, Dr. Sai. It's indeed a great pleasure to have all of you on board for our World Webinar for Ophthalmic Revisions, where we are taking a 3-hour session for each subspecialty. And in the 24 hours of program, we are aiming to cover 360 degree of ophthalmology for residents as well as comprehensive ophthalmologists. So we have, let me share my screen to you. We have our, the chairperson of this webinar is none other than Dr. Ronnie George. Can you see the screen?
Yes, you can make it full screen if you want.
Yeah, I'm trying to make somehow it's not coming full screen. Okay, so Ronnie completed his MBBS degree from St. John's Medical College, Bangalore, and MS Ophthalmology from CMC Vellore, DO as well as MS, and currently he's the director of the glaucoma services at the Shankar Nethralaya, Chennai. He is a regular fixture and event and chairman in almost all of our Cochin Ophthalmic Club as well as the Kerala Society activities. He's published more than 150 papers in peer-reviewed journals and indexed journals. He is also the section editor for the Indian Journal of Ophthalmology and editorial board member of the Journal for Glaucoma. He is currently member Education, Technology and Outreach Committees of the World Glaucoma Association. And he's a past associate advisory board member for the World Glaucoma Association and past secretary to the Glaucoma Society of India. So he will be assisted by Dr. Aditya Niog, who is a consultant ophthalmologist Foresight Worldwide. And he was previously a senior consultant at Shankar Nethralaya in glaucoma. And he's a reviewer for multiple peer-reviewed journals, alumni of the Leadership Development Program of the AIOS, and he was awarded the AIOS IGO Platinum Award. Abhilash Nair is our moderator from Cochin. He had his postgraduate from RIO Trivandrum and fellowship from the Arvind Eye Institute, Tirunelveli. He is currently the senior consultant of glaucoma at Giridhar Eye Institute, Ernakulam. And Dr. Manoj Prathapan is MS Ophthalmology from Amrita Institute of Medical Sciences, and he did fellowship of glaucoma from Arvind. He's associate professor of ophthalmology at Amrita School of Medicine, and he has also won Tony Fernandez Video Film Award in 2000. So these are our chair people and our moderators. Over to you, Dr. Ronnie, for a wonderful session on glaucoma, and I'm sure that these 3 hours will be etched into our minds and it will increase the knowledge multiple folds. Thank you. Over to you, Ronnie.
Thank you, Gopal, for the kind words and the invitation. And what he didn't tell you is that this is a very, very successful program, and last year had one of the highest attendances for any such program in the country. So it's good to be part of it. And I'll take the liberty of introducing the next 3 speakers, and then I will hand it over to the moderators to take it forward. Yeah. So it's a pleasure to introduce Manish Pandey, who is currently the Director of Glaucoma Services at Ratan Jyoti Nethralaya in Gwalior. And he does a lot of complex glaucoma in that area and is one of the few trained glaucoma specialists in that entire region. He was formerly a consultant with the glaucoma services at Shankar Nethralaya, as well as one of our very best research and clinical fellows that we had here. He did his MS and his MBBS both from the prestigious KGMC at Lucknow. He will be followed by Dr. Thomas George, who did his BO and MS from the Christian Medical College, Vellore. He worked in the Kerala Government Medical College Services and was Associate Professor in RIO Trivandrum. He is presently Senior Consultant Glaucoma and Cataract Services at Chaitanya Eye Hospital and Research Center in Trivandrum. He's been regular faculty at the KSOS, AIOC, and GSI in the past. In addition to that, I have learned a lot of ophthalmology for him, for which I'm forever grateful. Thank you, Thomas. And the third speaker in the session is Dr. Manish Singh. He's the Director, Netralayam, the Super Speciality Eye Care Center. He's also a Senior Glaucoma Consultant at BBI Foundation and the Joint Treasurer of the Glaucoma Society of India. He is a long-term glaucoma fellow from Shankar Nethralaya and was former consultant at Shankar Nethralaya, Calcutta. He's been an East Zone representative of the GSI in 2012 to 2014 and the GIEP program coordinator from 2016 to 2018. He's a very dynamic young ophthalmologist and very passionate about teaching. So I will stop sharing now and ask Aditya to take over and run this first session. Aditya, over to you.
Yeah. Thank you, sir. So now we start our scientific session, and I first invite Dr. Manish Pandey to speak on the Goldmann Applanation Tonometer, techniques and pitfalls. Dr. Manish?
Yes.
Your slides are seen.
Yeah, thank you. So we'll be talking about Applanation Tonometer, the technique and pitfalls. And I thank the Cochin Ophthalmic Club for the wonderful opportunity to present in this program. Now we know that the relationship between intraocular pressure and glaucoma is rather very complex from what we can see superficially. The Goldmann's Applanation Tonometer is a simple and widely used device. It has a low cost, but it is still considered to be a gold standard for measuring the intraocular pressures. Why is it that the Goldmann survives as one of the last analog devices in our increasingly digital examination rooms, just as this old clock does? Now we need to measure the intraocular pressure accurately. And we know that intraocular pressure is the only modifiable risk factor in glaucoma. The advantage that the Goldmann gives us is that it gives a comparison as it's the benchmark for IOP across major clinical trials to which we can correlate our patient. But whatever method we use for tonometry, the measurements are always an estimate of the true intraocular pressures. So we need to look at two things: an accuracy, that is how accurate means how close they represent the true intraocular pressures. And the second part is the repeatability, that means how close the measurements are to each other, that is also called as the precision. If you look at principles for applanation, it's basically the force that is necessary to flatten a given area. By means of invert Fick's law, the force is equal to a pressure into the area that is being applanated. But for this, it requires a perfectly elastic sphere, which is infinitely thin, and the RI does not fit into that criteria. And therefore, an increased accuracy of an IOP estimation by any device requires a proper instrumentation, a correct technique, and attention to ocular factors, which may include the rigidity, the central corneal thickness, or even a post-refractive or any other status. There's a common instrument that we know most of it, so that it can be easily integrated to our slit lamp. I'm just going to basic techniques. Basically, the bioprism is, there is a red mark and a white mark. The white mark is aligned at the white line, and a drop of topical anesthetic is applied. The patient is explained the procedure, and I usually use fluorescein strips to stain. The fluorescein solution has also been used, but there is a chance for infection. So we have changed more into strips there. The bioprism is illuminated by a cobalt blue filter, which is placed around 60 degrees to the bioprism by a low magnification and a high intensity light, as shown in the picture. And the adjusting knob is set at 1, that is around 10 millimeters of mercury. The patient looks straight and holds the lid against the bony orbit only if it is required, and the bioprism is slowly brought near the corneal apex. Now, when there is gentle contact with the corneal apex and using a monocular view, the observer sees through the slit lamp. Now, basically what this prism does, it splits the beam by two with the bioprism, and we need to look at the two semicircles there, and we may need to raise or lower the slit lamp till the semicircles are equal in size, and we adjust the knob till the inner edges just overlap. There are excursions. The excursions between the ocular pulsations are averaged, and finally the intraocular pressure is read from a scale multiplied by 10 millimeters of mercury. This is how the final picture, when we finally applanate, this should look like. The inner edges should just overlap each other. As told, it is affected by numerous factors, which may be instrument related, patient related, or procedure related. First, coming to the instrument related factors, very important part is calibration. Now, the manufacturer recommends a calibration within 0.5 millimeters of mercury at all the levels, that is 0, 20, and 60. CG guidelines would be a little more lenient at around 2, 3, and 4 millimeters of mercury at these three levels. So this is a calibration rod which is provided, and it has three markings there. One is at the center and two on either sides at 20 and 60 millimeters of mercury. And this is placed onto the applanation tonometer on the slot provided. A short video on how it does, and you have to see the movement of the biprism there. And moving on one of the sides, you can see the biprism moving in the front. We move back and see the tip of the biprism moving back. So basically, this applanation tonometer is calibrated within 2 millimeters of mercury at 20 millimeters of mercury. But how accurate are our tonometers? This is a study from southern India, from Shankar Nethralaya, in which if you look at the level of testing of 20 millimeters of mercury, what we commonly are using for our glaucoma patients, out of 132 instruments, only one was calibrated at all the levels of testing, and only 5 were accurately calibrated at 20 millimeters of mercury. If you look at the hospital protocol and the CE guidelines, which are a little lenient, around 60 to 70% instruments were under acceptable limits. What about two different Goldmann applanation tonometers which are perfectly calibrated? They will also give different readings. This was the Zeiss and the Inami. This was also a study done in Shankar Nethralaya, and we can see a statistically significant difference between the measurements between the two instruments. However, in 70%, the difference was within 2 millimeters acceptable difference. The authors state that baseline and follow-up IOP measurements, ideally, if possible, should be done on a single instrument. There are many other factors which may affect the intraocular pressures, which may be related either to the patient or to the procedure. A correct technique is important. The patient is instructed to sit properly on the slit lamp. Do not press the eyes while you are trying to applanate. The patient may shift his eyes up, and you can ask him, explain the procedure to the patient, and do not let the applanation tip touch the eyelids or the lashes there. That might give a different reading. There may be a paucity of the precorneal tear film or the hyperfluorescence there, which might cause an underestimation of IOP. At this point, we can use either a lubricating eye drops, or you can restain them and just recheck our pressures. In case of excessive tearing, there may be an overestimation of intraocular pressures. At this point, we need to wipe off the tears and recheck our intraocular pressures. Goldmann's applanation tonometer has been shown to have an effect because of the corneal astigmatism by around 1 millimeter of mercury for every 4 diopters of astigmatism. There is a red mark also provided on the biprism on the tonometer head, and we have to align this to the flatter meridian. Now that becomes a little tricky in some patients because we have to get the keratometry done. So it would be ideal in that sort of situation to check the intraocular pressures both in the horizontal and the vertical meridian and divide it by 2 to get an approximate idea on how we are trying to measure the correct intraocular pressures. A very important thing is about the central corneal thickness. The central corneal thickness, if it is on the higher side, it causes an overestimation of IOP because of the increased force that is required to applanate. However, the caveat would be in corneal edema, where the intraocular pressures may be artifactually low. In case of thinner corneas, there may be an underestimation of IOP because of the lower force required to applanate. There are different formulas available in literature which have been suggested to correct the intraocular pressures for CCT, but ideally none of them work to a correct level, and there is no accurate correction formula for CCT influence on the intraocular pressures. Take this study in which evaluated the tonometric correction factors. This is normals And if you see the uncorrected intraocular pressures, they show a rising trend as expected. But even if we correct the intraocular pressures to the CCT, we see a negative slope there, possibly because of the effect is not just because of the central corneal thickness. The authors state that the reclassification error could result in inappropriate management of subjects if they were treated only on basis of corrected intraocular pressures. The same happened in patients with OHT or POH. This was a study because of the OHTS in which they tried to see whether adjusting the intraocular pressures helped, and they found that it does not improve the prediction models for primary open-angle glaucoma. And you can see the graphs there. The gray ones are the unadjusted intraocular pressures, and the other lines are the adjusted ones for 5 different formulas. And it did not help. The authors state that the results of our analysis suggest the influence of central corneal thickness as a prognostic factor for development of PAG is not entirely because of its effects on intraocular pressures, and the central corneal thickness is a biomarker for structural and physical factors which may be more important in the pathogenesis of POAG. Another important point would be a post-refractive stages such as LASIK and PRKs, because this is not the only change in central corneal thickness, it is also a change in corneal curvature and corneal biomechanics, which can influence the measurement of intraocular pressures. So applanation readings actually underestimate the intraocular pressures following LASIK and PRK, and there is no perfect nomogram to estimate a true intraocular pressures after refractive surgery. So how do we proceed from this point? So practically it is more useful to classify the central corneal thickness as either thin, average, or a thick, and do not correct the intraocular pressures for central corneal thickness. And how do we use it? So in case of ocular hypertension with thin corneas, we may say that patient has a greater risk of converting to POAG, and a glaucoma patient with thin corneas will have more chances of disease progression. The larger picture is that we still don't know how the intraocular pressure and the intraocular pressure fluctuation affects the human eye, because it's a dynamic phenomenon. We are only checking it at certain points during the day with certain instruments. We still don't know how it actually affects throughout the day. So minimize this sort of variability. Take a mean of 2 consecutive readings at each measurement. And if the difference is more than 2 millimeters of mercury, take a third reading. And you can take a median of the 3 readings. Take multiple diurnal measurements and do measure the central corneal thickness. And if possible, have a monthly calibration checks on the instrument that you're trying to use. So finally, because of the long history of use, reliability, and a good reproducibility and use in clinical trials, Goldmann still remains the gold standard for our intraocular pressures. Understand the situations where the measured intraocular pressures may be misleading with this instrument, and understand that there is no accurate correction formula for CCT influence on the intraocular pressures. Thank you.
Thank you, Dr. Manish, for a very comprehensive talk on applanation tonometer. We will now have the next talk, and then after 3 talks, we'll have a discussion. So I now invite Dr. Thomas George to speak on a very important part of glaucoma, especially in our part of the world. What's in an angle, the gonioscopy, to assess the angle.
Thomas, are you muted? Please unmute and probably start your video also.
Sorry for that. Thank you, Cochin Ophthalmic Club and Ronnie and Dr. Aditya for giving me this opportunity to speak on this session. The talk will be primarily on how to start learning gonioscopy and then go into a few clinical pictures at the end. What is in an angle? It's a rhetorical question, primarily because even to diagnose an open angle glaucoma, you need a gonioscopy. It's not just closure. We think closure means gonioscopy, but we have to know that it is not a closure to say it's open. No secondary glaucomas. All that needs gonioscopy. For the procedure, the start of the procedure is to explain it to the patient. It's scary for somebody to have something stuck into their eye. So explain the procedure to the patient, put in a topical anesthetic drop, seat the patient comfortably at the slit lamp, make sure you're also seated comfortably at the right height. So you need adjustable stools on both sides of the slit lamp as well as slit lamp that can move around. And for the procedure with a 4-mirror lens, these are smaller lenses as far as the corneal end is concerned. Ask the patient to look straight, insert the lens gently to touch the tear strip. The tear strip will get into the interface between the lens and the cornea and get rid of an air cornea interface. And slightest pressure and you're indenting and the angle would actually open up. So you have to be very gentle here. With the Goldmann lens, a 2-mirror lens is what I prefer most of the time. You can either ask the patient to look down like so, place the lens edge so that at the inferior limbus, you are retracting the lower lid with the lens edge. You can rotate the lens onto the cornea and ask the patient to look straight. Alternatively, you can make the patient look up, place the lens ready to be slapped onto the cornea. As the patient looks straight, you can put it onto the cornea. You need a coupling fluid for these lenses. You just need 1 drop in there actually once you've got some experience, because more than that would be flowing down the patient's cheek and that's not comfortable. For slit lamp adjustments, a vertical slit beam, illumination slightly tilted to one side and the microscope straight is for 12 o'clock and 6 o'clock mirrors. You need a parallax to really see in 3D. So you need a slight parallax, not coaxial. But when it comes to the 3 o'clock and 9 o'clock mirrors, you need a vertical parallax because you're going to rotate the slit beam to a horizontal position. And this is done like this. You rotate the mirror so that you're at 3 and 9 now. Rotate the slit beam so that it's now horizontally aligned. And you need to tilt the housing so that you achieve a vertical parallax so that you can appreciate in 3D. Gonoscopy, when you start putting in a lens, we want to grade the angle. Is the angle closed or occludable? How much can it potentially open? And is there any secondary features? So the start of the whole show would be to find the anatomical landmarks. The anterior-most landmark we are looking for is the Schwalbe's line end of the Descemet's membrane. And that is where the corneal epithelial line, the endothelial line of the corneal parallelepiped come together, and that is the Schwalbe's line. Behind that would be the trap measure. Schlemm's canal is not often seen. It's seen as a pink line in the middle of the trabeculum if blood has refluxed into the Schlemm's canal. And trabeculum has a granular appearance. The pigmentation can vary a lot, color can vary a lot in normals. So that would be pathological in some situations, otherwise could even be normal. Scleral spur is a glistening white line at the posterior edge of the trap meshwork. It's a very thin line. Behind that, we would see a gray ciliary body band. Both these lines are usually broken. It's not continuous in most patients. And then you see the root of the iris. Often we are stuck with an angle like this, where you can't make out anything. There are iris processes that are blocking and making things more confusing. To know where the trap meshwork starts, you really need to look at the parallelepiped, and that is a Schwalbe's line. So this would be a trap meshwork, and it's an open angle. And this is a normal angle, by the way. An anatomical grading is what I prefer. Madan Mohan's grading, which is RP center grading, uses numbers for the same. And we need to add a note on occludability. That's a subjective note on the angle between the iris and the peripheral cornea as you see it in the gonio lens. For minimum ambiguity, we record the posterior-most structure that is seen, and as a ciliary body band, a CBB, or any short form you want, so that other people can understand when they read your notes. And quite often, you have to tilt the gonio lens slightly to see the posterior-most structure. That's because in quite a few angles, we have the lens sticking in a little bit into the central cornea, central AC, a peripheral bump of iris there, which would prevent you from seeing this area as opposed to seeing this area, which you would call close when it's actually open. A large diameter 3-mirror lens is not appropriate because it will hit the bony rim of the orbit and will not allow you to tilt the lens like this. This is how we peep over the lens. You go along the curve of the cornea, so the angle of the lens to the antechamber angle is changed, so that you're going deeper into the angle in your view. Hope my video works. Sorry, that video didn't work. The aim is to see the angle at its narrowest when we start grading. So you want a dim room, dim illumination, short beam that stays out of the pupil, thinnest beam, and this particular angle, the Schwalbe's line is yet to be evident, so it's a totally closed angle. When we increase the light and the pupil starts to constrict, quite often you start seeing more of the angle. Here it's become grade 2. It's the same angle I'm showing you as I go through a few photographs. And once you hit the pupil, watch this pigment here. You're seeing the back end of the pigment here, and it's grade 3 as per the Mother Mohan grading. That is the middle trap. To see further, you need to indent. Corneal apex is indented, the limbal ring is stretched, peripheral cornea is pushed out, essentially like a book opening at its spine. The structures in the angle are splayed out, and you can do the same with the 2 mirror by asking the patient to look towards the mirror you're examining. Suppose you're using superior mirror, you ask the patient to look up, and you resist the patient's eye movement by sliding the lens straight down gently, otherwise the air bubble will come up and the lens will come off altogether, so that the edge of the lens is indenting the cornea. When you do that, the same angle, this was the pigment we were seeing before, it opens way beyond, and you can see the ciliary body band here, the gray here. So, I'm sorry, my videos don't seem to be working here. That is peeping over the hill, and this is indenting. Let's try to say that again. Peeping over the hill, you're seeing deeper in the angle, and when the patient looks up, you can see further into the angle, and that's indenting. Okay, so these 4 pictures are of the same angle. So if you've gone step by step, you've picked up an angle closure, which needs a one-time PI. But if you had gone in with full illumination and a little bit of pressure on the cornea, you would have seen an open angle and would have treated him as a POAG. The same is achieved with 4-mirror lens by gently touching the lens onto the cornea, dim illumination, angle is closed, you press slightly and you have an open angle. That is a closed angle which is potentially capable of opening up. You press a little more, you will have Descemet's folds, and then you can't see the angle. So you have to be very gentle with all these maneuvers. Look for other features like PAS, pigments, features of secondary glaucoma. After you grade the angle, you record the minimum angle grade to maximum it can open up to in all the 4 quadrants, and any other features recorded by the clocker. Now I'll go through a few features we need to identify when we see on gonioscopy. You have synechiae like this, which is smooth, slight change in up and down. That will be an appositional closure, angle closure with PAs forming. Whereas we guys have got quite a lot of creeping closures. The height of the synechiae tends to be uniform in these cases. Again, it is smooth edge, as opposed to an inflammatory synechiae, which is usually inferior and the edge is irregular, moth-eaten, like this, and it needs to be differentiated. You should not confuse them with iris processes, which are just strands of iris and not full thickness iris that's plastered onto the angle. In a plateau iris configuration, one would see the illumination beam on the iris suddenly disappearing. It is broken off there, and if you indent, you would have the so-called sine wave sign that is down, and up again. What is happening is usually it goes down, drapes over an anteriorly placed ciliary process, then goes down, comes onto the natural curvature of the lens. That's a sine wave sign. And these angles may open partially with PI, needs other treatment otherwise, so you need to identify these. I said pigmentation can vary a lot in normals. This pigmentation would definitely be significant. Well, carpeted brown, it's an open angle which is totally brown. This is a Sampolisis line, coarse pigmentation. Both are significant because there are other findings to see in the eye. There's pseudoexfoliation corresponding to this, Krugenberg spindle corresponding to this, pigmentary glaucoma, pseudoexfoliation glaucoma. Angle recession, you see a wide ciliary body band. It's not enough to say wide, irregularly wide ciliary body band, and torn iris processes are also there. This is a good picture to show that, because you've got an obviously irregular widening of ciliary body band, a piece of iris process sitting on a trap which is not connected to the iris, that's a torn iris process, and a black spot there in the angle. That's a remnant of an old hyphema sitting there. There's a black spot, black, not brown. Brown could be pigment. In trauma, one may get even a cyclodialysis where you see a slit of sclera through the angle beyond the ciliary body. If you indent slightly, it would fish mouth open and close. You get only one chance to indent because eye would become really soft after that. And even a small iridodialysis like this would be missed on slit lamp. But with a gonio lens, you see the peripheral cornea, peripheral anterior chamber, and small hyphemas like this can be missed on slit lamp, but you pick it up on gonioscopy. Neovascularization on the iris is easy to pick up, but when it comes to the angle, you need gonioscopy skills. You see a vessel that's crossing over from the root of the iris onto the surface of the trap network and branching on the surface. You call it a neovascularization. Sometimes you do see normal vessels sitting in the angle. They're thick vessels which are not branching. You may see deeper vessels from episcleral vessels through the trap measure translucency, perforating vessels through these areas. Those are not abnormal. A branching one on the surface of the trap is what you're looking for. Once NVG forms synechiae, you can still identify them because at the anterior edge of the NVG synechiae, you have the network of vessels sitting there. It's a vascular synechiae at the anterior edge of the synechiae. In a trabeculectomy, sometimes we need to do a gonioscopy to see what is causing its failure. Here you have an ostium that is open, but here you have some iris tissue. Root of iris is missed in the PI, going in and plugging the iris of a trabeculectomy ostium. And that is not going to work if you go and needle that trap. You need to do something about this iris. Axonfeld anomaly, you have a posterior embryotoxon and bridging synechiae that are going onto the posterior embryotoxon with a gap behind which is obvious on 3D, which you see when you're seeing gonioscopy. And in iris corneal endothelial syndrome, you may have a slightly hazy cornea, but if there's a corneal edema, you have a broad pulled up synechiae, sharply pulled up, broad synechiae, which may even go beyond the trap measure onto the cornea due to a contracting membrane. It's not only for glaucoma that we need gonioscopy. You see the peripheral cornea, peripheral anterior chamber. This was a peripheral corneal edema which is progressing in a young person, 20s age group, and there was an angle foreign body. There was a history of a corneal tear that we could pick up after we found this, which was sutured 10 years prior to this, and that stone had to come out. You may also find very curious findings like this. This, by the way, is one of those glued IOLs, and the cataract surgeon has managed to do what we find difficult, cantilate the axial Schlemm's canal with haptic. And sometimes I do come across findings like this. It looks like on cotton wisp sitting there, nothing wrong with the patient otherwise, IOP-wise, no other problems. Only this, I have no idea what it is. I'm assuming it's some past inflammatory membrane that has been left behind. Thank you.
Thank you, Dr. Thomas George, for a wonderful presentation and the video. So we now move on to the next presentation by Dr. Manish Singh, who will be speaking on the overview of glaucoma drugs, the efficacy and side effects.
Thanks to Cochin Ophthalmic Club. Am I audible, sir?
Yeah. You are audible.
Yeah, thank you. Thanks to Cochin Ophthalmic Club, Dr. Ronnie George, sir, and Dr. Aditya Niyok, sir, for this opportunity. So I'll be giving a very brief overview about the common glaucoma medications. Before we start discuss about the mechanism of action, I'll discuss about the evolution of these glaucoma drugs. Even now we are using pilocarpine, but we see the pilocarpine was actually introduced almost 150 years back. One of the landmark drugs which was introduced was timolol or beta blockers in 1978, more than 40 years back, and it changed the way glaucoma was treated. But one of the most important anti-glaucoma medication, that is the prostaglandins, were introduced almost 25 years back. And it has been seen after that introduction of prostaglandin, overall glaucoma has been treated more medically, and the number of glaucoma surgeries have actually gone down over the last 25 years. And then the combination drugs were introduced. We had newer prostaglandins, and now the most recent ones are the ROCK inhibitors. if we need to understand the mechanism of action of anti-glaucoma medication, we need to see the aqueous humor is secreted by the ciliary body, and it drains outside through trabecular meshwork and the uvascular outflow. So we can decrease the aqueous production by decreasing the production of aqueous. So the drugs can work in two ways. One, either they can decrease aqueous production, for example, the beta blockers or the alpha agonist and the carbonic anhydrase inhibitor, or we can increase the uvascular outflow like the prostaglandin, or we can increase the trabecular outflow like the myotics and the ROCK inhibitors. The alpha agonists actually increase the uvascular outflow also, along with decreased production of aqueous humor. So there are broadly 5 classifications of anti-glaucoma medication. Prostaglandin are the most important group, the drug of choice in most of our patients, and latanoprost has been the first prostaglandin which was introduced in market. The most recent one is the latanoprost bunode. Timolol is the most commonly used beta adrenergic blocker. Betoxolol is a cardio-selective beta blocker which has less side effects on the lungs, so it can be used at least theoretically in patients with COPD also. Alpha adrenergic agonists, we have brimonidine, carbonic anhydrase inhibitor. Topical, we have dorzolamide and brinzolamide, and orally we have acetazolamide, and pilocarpine is the available cholinergics we have. So these are basically the 5 groups of ocular hypertensive drugs we have, and the most recent one is the ROCK kinase inhibitor, and we have a separate presentation on this. Overall, seeing the efficacy, definitely prostaglandin, all the 3, bimatoprost, travoprost, and latanoprost have been the best IP lowering drugs available. This table I have prepared for the most recent EGS guideline, and as per them, prostaglandin gives you around 25 to 35% IP reduction, which is maximum among the all anti-glaucoma medication, followed by beta blockers, brimonidine, netarsodil, and even interestingly pilocarpine, which can give you anything from 20 to 25% of IP reduction. The next line we have the betoxolol, topical carbonic anhydrase inhibitors, and ripasodil, which give you around 20% IP reduction. Oral carbonic anhydrase inhibitor, that is the acetazolamide, can give you as high as 30 to 40% IP reduction, but they are generally used for short course because of their potential systemic side effects. Compared to timolol, the reason prostaglandins are the best first-line drug, one, because of their better IP control, but also because of their hardly any systemic side effects, and they give you a 24-hour IP control compared to a beta blocker or an adrenergic agonist, which is dependent on adrenergic stimulation. So they work better in daytime compared to nighttime. I'll quickly go through the common side effects and their contraindication. Starting with prostaglandin, we all know the most common side effect is conjunctival hyperemia. Along with long-term use leads to periocular pigmentation, increased iris pigmentation, lengthening of the eyelashes and thickening of the eyelashes. Plus, the patients who are prone for CME, for example, patient with posterior capsular rent, can develop a cestoid macular edema. Since these are pro-inflammatory drugs, so definitely they should be avoided in any form of inflammatory glaucomas, any patient with any herpetic eye disease, plus patient with cestoid macular edema and pregnancy. Coming to beta blockers, the most common ocular side effect is dry eye and irritation. Plus, they do have systemic side effects. For example, they can aggravate your bronchospasm, can lead to heart failure in patients who are prone for heart disease, and long-term use can also lead to depression. So they should be avoided in patients with second-degree and third-degree heart blocks, any patient with COPD, patients who are on systemic beta blockers, and patients who have sinus bradycardia. It is also important to reduce the systemic absorption of these anti-glaucoma medications, especially drugs like beta blockers. So after putting eye drop, you should keep your eyes closed for at least 3 minutes and practice punctal occlusion. Brimonidine is notorious for allergies. It can lead to allergic conjunctivitis, blepharitis, and also contact dermatitis. Can also lead to dry mouth and dry throat. Plus, another important complication is excessive sleepiness. So a lot of patients after putting brimonidine do complain of increased sleepiness. And in those cases, we may have to stop brimonidine. They should definitely be avoided in children less than 5 years of age, and also on patients who are on oral MAO inhibitors. There also have been discussion about neuroprotection. So neuroprotection basically is directly preventing the neuronal damage on non-IP reducing mechanisms. There are certain drugs like brimonidine or ginkgo biloba and citicoline who have been used as protective neuroprotectives, but currently, if you see the literature or the guidelines, none of them are actually proven neuroprotectives. Coming to topical carbonic anhydrase inhibitor, both brinzolamide and dorzolamide give you equal IP reduction, but brinzolamide has the advantage that it has less irritation and stinging, and plus being a suspension, you can have transient blurring of vision. Both of them can lead to allergy, hyperemia, burning sensation, bad taste in the throat, can lead to superficial punctate keratitis. These should be avoided in patients with low endothelial cell counts, like patients with fugues or after any penetrating keratoplasty. Oral acetazolamide, as I've already discussed, are very potent in decreasing intraocular pressure, but they have side effects. For example, paresthesia, they can lead to hearing problems, and GI disturbance are extremely common, and sodium potassium imbalance can also happen. And it is why a lot of these patients, when we are using for long term, we do give potassium supplements. They should be avoided in any patient with sulfur allergy, any patient with electrolyte imbalance, and any renal or liver disease. Pilocarpine does increase your trabecular mesh flow outflow, but in PSEG patient, it also has the advantage that because of meiosis, it opens the angle. And this is especially useful in patients with plateau iris, and also useful for constricting the pupil before laser iridotomy. But its side effects are like meiosis. It can lead to brow ache because of it causes accommodation, and can also lead to myopic shifts. It should be avoided in any patient with inflammation, because again, they are pro-inflammatory. So any uveitic glaucoma, patient with neovascular glaucoma, we should avoid pilocarpine. Also avoid pilocarpine in patients who are predisposed to retinal detachment, like patients with lattice and holes. Before we conclude, I'll touch about the hyperosmotics, which are again used mainly for acute conditions like acute angle closure glaucoma or post-operative glaucoma with acute rise of intraocular pressure. We have the options of oral glycerol and IV mannitol. They should be avoided in patients with any cardiac failure or renal failure. The dosing is also important. For example, IV mannitol, the dosing is body weight into 5. So if you're using a 20% mannitol, so if suppose the body weight is 70 kg, you should use 350 ml of mannitol IV over a period of 20 to 30 minutes. Monitoring of vitals is extremely important for these patients, because a lot of these patients may develop headache, dizziness, altered sensorium, or vomiting. A little bit about the combination drugs. Combination drugs also are available since 1960. Most of these drugs have been with beta blockers, but the more recent ones like the brimonidine with brinzolamide or nitazoxanide with latanoprost are the one which don't contain a beta blocker. The advantage they have is that, one, because of the additive efficacy, it is better tolerated, there's less preservative exposure, and also it is more cost effective. So to conclude, I'll say there are a lot of drugs to choose from, and we have to be informed about whatever their efficacy, their side effects and contraindication, and choose judiciously whatever is best for your patients. Thank you.
Thank you, Dr. Manish, for an excellent presentation. You have very wonderfully shown all the different drugs that we can use, and main points highlighted as that combination therapies, if we can give, that will always help. Like now, although we have a talk later on, but how many drops maximum number of drops would you recommend for your patient, like in a day, like different medications, number of drops?
So generally we try to use 2 bottles or 3 drops per day, maximum say 4 drops per day. So suppose we definitely use prostaglandin if not contraindicated, and along with that timolol with brimonidine or a timolol with a brinzolamide or dorzolamide combination can be used. Nowadays we also have timolol with the prostaglandin combination, which can be used with a brinzolamide brimonidine combination. So we can get in 2 bottles, and 3 drops we can get 4 drops. So we generally try to avoid going beyond 3 or 4 drops, because then it becomes very difficult for the patient to use.
Compliance becomes a problem. One more question that I had, because you have a very busy practice and all, many times we just prescribe the drops and tell the patient to take. Do we demonstrate, at least for a new patient, how to put the drops? Anybody in your clinic does it or something like that? That is anything.
So what actually, again, in a busy practice, it's difficult actually to demonstrate it yourself. But what I've been doing, I do use a lot of educational material where I give to every patient, especially any newly diagnosed glaucoma patient, where it is very nicely demonstrated how to put the eye drop, how to do the punctal occlusion. we have prepared certain videos also, which we have kept on our website of our hospital. So we asked our patient to go and have a look. There are a lot of question answers also about glaucoma. So we do tell them to use them, because not everything is possible to discuss in OPD, but educational material and videos are definitely useful.
Yeah, so that is very important, because prescribing alone is not the thing. Dr. Sai, did you have a question?
Yeah, I mean, there has been a lot of talk about the use of prostaglandins during cataract surgery. There was a time when we all used to stop the prostaglandin, and nowadays we don't stop that. What is the consensus among the panel regarding that? What I'm doing is, now for all these, initially I started using for all patients. I had a series of pseudophakic CMEs, and then I'm giving Nepafenac to all these patients without actually stopping the prostaglandin. But what is the general consensus in the panel regarding that? Dr. Manish, and if any other comments from the others.
I'll share my experience, sir. We have been using prostaglandin till the day of surgery, and after surgery we stop prostaglandin for 2 weeks. And once the eye is quiet, there is no inflammation, uncomplicated surgery. Mostly after 2 weeks to 3 weeks we start. But again, I also had an experience that few cases after 1 month and all, they did come back with pseudophakic CME. So nowadays I use an anti-glaucoma medication, either a beta blocker or a beta blocker with some combination, not prostaglandin, for a month, and then we restart the prostaglandin.
Yeah, that is, I think most people would, that is what I also do, try to stop the prostaglandins for a month at least if possible, post-surgery, and then restart. Ronnie, sir, any comments?
Yeah, I do the same. I keep it off for about 8 weeks, and I usually keep them on a topical non-steroidal for 4 to 6 weeks after surgery, but I don't stop it immediately before surgery. Manish, I had another question for you.
Yes, sir.
Because you have so many generics of every drug that are available now, and a patient, you prescribe one thing, the patient gets another one, the next month it's a third drug of the same molecule, but you get 3 to 4 different brands. Do you think it's advisable to do that?
So definitely the problem with generics is that theoretically it's the same compound, but the bioavailability of the drug is not same, and the amount of drops is not same, the side effects are often more. But problem is the cost issue is definitely we have to address in our country. So a lot of time we do see patients who have taken an innovator molecule, have gone to the pharmacy, and the pharmacy have suggested a much cheaper option, and they do call us. So what I tell my patient, if cost is not an issue, try to use the better company molecule. But if they generally have a cost issue and they are not able to afford, so instead of not using any eye drop, they can use a generic. But it's not advisable to keep changing the brand, because changing the brand can affect the IOP control also.
One more point I wanted to ask you, Manish. Like, if you get a pregnant lady, like, how do you handle? What are the medications if she's already on some medications, or planning pregnancy? What do you do?
Mostly in pregnancy, we see the IOP comes down. But in case the patient is planning to get pregnant or patient is already pregnant, so brimonidine is the best drug for pregnant ladies, especially in the first 8 months. In the 9th month, we should stop brimonidine, and we should stop brimonidine in lactating or nursing mothers, because it can cause CNS depression in kids. So brimonidine should be the best option. Theoretically, we should avoid prostaglandin, because prostaglandin can cause abortion, but then there are no reports in humans about that. But you should avoid prostaglandin. And
do you consult with the obstetrician of the lady while treating, or you treat independently?
Mostly we treat. If there's any other associated health issues, we often consult, but not routinely for all patients.
Yeah. Dr. Abhi wanted to say something.
May I just sorry. For pregnancy, SLT is an excellent yes. procedure to try to get people off drops as much as possible. And if this doesn't work and you have to do timolol, that's the one time that it's important to talk to the obstetrician, because they monitor the baby for IUGR or any other issues.
Yeah, can I just add on that prostaglandin issue? I had to get used to not stopping prostaglandins after coming to this country. And it is probably a lesser risk than the pressure going up post cataract surgery. So as a routine, I don't stop unless there is something to tell me that there is something not quite right here. Quite often it's a UVA text or something that I tend to stop, but otherwise we don't stop prostaglandins. And in this country, probably shed loads of cataracts are being done on people on Xalatan and nothing really happens. And again, on the flip side, we know that when this macular edema does happen, it's a totally reversible condition. So it's not end of the world.
So same thing here. We don't stop prostaglandins before cataract surgery. And the CME has been shown to be caused by endogenous prostaglandins rather than exogenous prostaglandins. So using a non-steroidal for anyone at high risk, if you've had a rent or something, works not always, but pretty well.
Thank you. Dr. Manish has to go. We will go to the next presentation and we'll discuss the applanation tonometer.
I think Bhaskar had a comment to make. Bhaskar?
Yeah, we concentrate more on the molecule, but I think the recent evidence, which probably the pharmaceutical companies keep it to themselves, would be the preservatives that are important as well. Because we all know about the BA case, but the purite and other preservatives, they tend to work in different ways as well. One, in terms of decreased ocular surface problems. Second, also in terms of increased corneal penetration. I had recently a patient who was on alpha-Gen P, and when he was changed to alpha-Gen Z, the IOP lowering was much better. I don't know for what reason. May not be the case in every patient, but this happens. So we need to probably have more evidence on what kind of preservative gives you a better efficacy as well as better ocular surface. And I think we need to get in more preservative-free medications into the country. We should try to lobby with the pharmaceutical companies as well. That's my comment on the medications.
On that topic, can I just add that it's not just about the molecule. It's also about how that molecule is got into a solution. Okay, and of course, the preservative is an issue. So different pharmaceutical processes are used, and we don't know what is going on behind the scenes. So I think that's one of the main reasons why it's different, because more often than not, the preservatives are the same, except in the alpha-Gen story.
Yeah, just I want to make a quick comment regarding the generic medications. In the Indian context, I think there has been a lot of publications on the same. Of course, there was one study back in 2008. I think Dr. Arun Narayan was the chief author. Even you forget about that study. In RP Center itself, there has been comparison between the branded medications and the generic brands in terms of their physical properties. They were looking at the active drug concentration, the pH, the osmolarity, and it was found that they were slightly different. It's like all the generics were not the same, but some of the generics, interestingly, had all these properties very much within the tolerable limits of the branded ones. And interestingly, these were the generic ones which are also more expensive compared to the cheaper generic. So I'm just making that comment. There has been a lot of work on this in India itself.
So in the interest of time, we'll go on to the discussing about ablation tonometer. So Dr. Manish Pandey, he has very eloquently covered the whole thing. One important thing we have seen many a times, many of the pharmaceutical companies will give a corrective normogram for the CCT. So it is very important that we don't use a normogram as such. Many times they will say this is the corneal thickness is so much, so the corrected IOP is so much. So that is something which I think should be avoided. Dr. Manish.
Yeah, that's very true. That's what I highlighted in the presentation also, because
yes.
if we correct the intraocular pressure for the CCT, we are landing up more into trouble.
Yes, many times we will have medical reps coming with these normograms. So that is something which we should make sure that it's not there.
Take the central corneal thickness as a risk factor and assess it as a risk factor. Don't correct your intraocular pressure for the central
based on the numbers. Like now, one very important thing that you had said, like we need to calibrate the instruments regularly. How frequently do you calibrate in your?
It's probably a monthly calibration check would be okay.
Okay.
No, basically, when we do the calibration, it is done at 3 levels, 0, 20, and 60. So even if you don't have a calibration rod, it can easily be calibrated at the 0 level. You can do it without any rod also. So you will require the rod only when you're trying to test it at 20 and 60. So 20 is important for us because that's the intraocular pressure that we are usually checking at, somewhere in the 20s range. So it's important to check it at least once a month because there is some minor error in the instrument that may reflect into your intraocular pressure. So if you're trying to check something very accurately, at least our instrument should be accurate as any other instrument. So that's the only reason when you should be checking it. Probably a monthly calibration check. Doesn't take much time. It hardly takes a few seconds to check your instrument, whether it's calibrated or not.
And I guess one can have a calibration log also. Somebody can maintain it. That is important. In a big hospital where many people are seeing. And the other thing which is important, like machines, intra-machine, there can be variability. So preferable to check in the same machine with patients. Like that is important.
So sometimes what happens is that we are trying to do a diurnal variation and that it checks into 3 different rooms. So that doesn't make sense. So trying to do a proper sort of variation check, have a same instrument, same person, same machine. So that's
that is very important. The other thing is like many a times people are hesitant to take the intraocular pressure in post-operative patients. Like, so if required, what special precautions do you take to check the intraocular pressure in post-operative patients?
Basically, we check the intraocular pressure for all post-operative. Say you're doing a trabeclectomy or combined surgery, you definitely would like to check the pressures the following day. So only thing that you need to know is that use a fresh bottle. I usually use a fresh bottle of proparacaine when you're trying to assess the patients on the following day after surgery. I use fluorescein strips which come into the market, and I also make it myself by means of the Wattman papers, and I make it into my own OPD also. So I make it into small packets and I sterilize and I keep it with me, and I open 1 pack every week. The other option nowadays that I'm doing is I can procure it from the market and I can use it single sleeve every time. And we have to clean our tonometer tip. So I usually use alcohol swabs. The other option is to use bacillocin or 2% to clean my tonometer tip before I use it for every single patient. The only thing is I try to dry your tonometer tip before you try to assess it. Sometimes what happens is sometimes optometrists, they'll just clean it with the tip and you'll apply it straight to the eye. So that might cause a corneal aberration.
How frequently do you do DVTs like?
Not very often because it crowds the opening to a certain extent, but definitely in certain situations where I find that the patient is progressing despite fairly normal looking sort of intraocular pressure, and I want to see whether there is a fluctuation that is happening there. That is one of the conditions in which I like to assess whether there is any change that is happening, or I find that the patient is coming to me and his pressure say somewhere around 18 and he's having a fairly moderate glaucoma there. I need to find out what sort of pressure fluctuation is there. So in certain situations, when a patient is especially progressing and despite all therapy, I'd like to assess the intraocular pressures throughout the day.
Thank you, Manish. Now, this presentation on gonioscopy was so exhaustive. It was done in such a good way, Dr. Thomas. Like, how frequently do you do gonioscopy in your follow-up patients? Like, in open angle glaucoma, like, how frequently would you advise them to get a gonioscopy done?
Okay. Whenever I think there is a change, I would do gonioscopy. Whenever I think there is a change. Otherwise, the rule of thumb for me is once a year for all my glaucoma patients, be it open, closed, whatever, once a year. That's one more thing I check as I go along for all my patients. But if I think there is a change that has happened, if a secondary glaucoma is suspected or something which can happen in any patient, I would do an extra gonioscopy. Otherwise, once a year.
Okay, so that is very important because many times we have a gonioscopy in the first recording, then after 5 years, no gonioscopy done. Many times that happens, so that is important. And like for a beginner, which gonioscope would you advise them to start learning with?
It's much better and easier to focus with a 2-mirror lens with a coupling fluid. So that is what a beginner should go for because identifying the anatomy is the first step.
Okay.
Later on, you can switch to foam mirror, which is less messy, which all of us who are experienced are using. It takes much less time. But
so that is
two mirror.
So start with a 2 mirror, then graduate onto a 4 mirror so that you can do it faster and do a good indentation. So I think in the interest of time, we will go on to the next session. Thank you, sir.
Can I just add one little bit on the tonometry bit before we go on to the next one? One is calibration probably should be done every day in a busy clinic because otherwise in a month's time, you see shed loads of patients and you've lost the opportunity. And maybe each doctor, when he or she gets into his or her clinic, can always quickly check that zero movement, whether it's happening or not. And that's a quick check as well. Second thing was that about the CCT. CCT is a bit of what the Americans call a head fake. You can have a stiff, thin cornea and a floppy, thin cornea. Similarly, you can have a stiff, thick cornea and a floppy, thick cornea. CCT is just an indicator that just warns you that this might be a floppy sort of cornea. So just need to bear that in mind always. It's just one number, but you have to use it as part of the big picture. And one other thing, mask can sometimes come in the way of taking a pressure. Just watch your little strand that stands up, because sometimes it can touch the mask and
yes.
alter your
the COVID era. That's the new thing. Okay, thank you.
So
we'll go on to the next session.
Thanks, Aditya. So we'll just move to the next three speakers, and it's a pleasure to introduce Kiran. Kiran is a consultant in glaucoma at Precise Specialty Eye Care at Trivandrum. He did his MD from RP Center and senior residency there too. He got the Best Resident Award at RP Center. He has some index publications, and he's a very sensible speaker and sensible teacher, and we're glad to have him with us today. Dr. Gauri is a consultant in glaucoma services at Prabha Eye Clinic and Research Center and the Vitala International Institute of Ophthalmology. She was author or co-author for the Best Paper Award-winning paper, Best Paper Award-winning paper in the GSI conferences 4 times. I think that's a unique honor nobody else has had, 2003, 5, 7, and 10. She's the recipient of the IGO Platinum Award for the Best Publication 2019. She was involved in a project Diana, which empowers rural and semi-urban ophthalmologists in Karnataka and provides glaucoma care project provided by the World Diabetes Foundation since 2006 Feb. She's also an excellent teacher and provides really practical tips on how to manage the disease. And the last speaker in this session is Dr. Arun Narayan, who is currently senior staff physician at Singapore National Eye Center. He was a consultant at Shankar Nethralaya, Chennai, and a former senior consultant at ICA Noida. I know he hasn't written it, but he's extensively published and has a lot of research experience in all this, in addition to being a gourmet expert on which are the best places to eat and drink globally. So with this, over to you, Manoj, to introduce the session.
Thank you, sir. The first talk, I invite Dr. Kiran Gopalakrishnan to talk on a very important topic, systematic optic disc evaluation. Over to you, sir.
Am I visible and audible?
Yes.
Thank you. Thank you to Cochin Ophthalmic Club. Most of the panel members here are like my gurus. It's a privilege to speak here. I'll be speaking on a systematic evaluation of the optic disc. So if you look at the disease definition of glaucoma from the Asia Pacific guidelines or the American Academy, you find that they define glaucoma in terms of structural changes in the retinal ganglion cells, the neuroretinal terminal nerve fiber layer, with minimal emphasis on the other ancillary tests. So you could argue that the very definition of glaucoma is disc-based. So it stands to reason that a proper and systematic disc evaluation should not only provide the first clue to diagnosis, but one could argue that it should be able to provide you a definitive diagnosis and even a basis for treatment. And obviously, serial evaluation of discs can help you in assessing progression as well. Let's start with there are 4 main disc parameters that I'd like to emphasize upon. I'll start with disc size, and let's look at 3 different discs, and your attention is immediately grabbed by the one on the extreme right because of its large cup disc ratio. But the problem is that these discs can be of different sizes, and your cup disc ratio can vary with disc diameter or disc sizes. So the larger the disc, the larger can be the cup. In other words, large discs can have large cups in healthy eyes, and small discs can have small cups. So the Blue Mountains eye study, which looked at the optic disc size and its correlation to the vertical cup disc ratio, basically understood that with medium discs, let's take medium discs at 1.4 to 1.7 and anything outside it as small and large. And you find that the average cup disc ratio is correspondingly different. It's actually larger as the disc size increases. And if you look at the 97.5 percentile, which would be the upper limit of normal of cup disc ratio, you will again find that it is much higher for a large disc. So if you take an average of say 0.7, which is generally considered as the cutoff of your cup disc ratio, a 0.7 could be absolutely normal for a large disc, falling well within the 97.5 percentile, but could be well outside this percentile for a small disc. And sometimes asymmetry of the disc between the 2 discs of the same person can happen and give an illusion of a CDR asymmetry. In this case, on the one on your left is actually a larger disc, and the one on the right is actually a smaller disc, though there is no actual asymmetry here. So there are various methods of measuring the optic disc size. Population studies like the Blue Mountains looked at using HRT, but the simplest practical example is to use your slit lamp biomicroscopy and use your correction factors, whether you're using 78D or 90D. And I have switched over to using a 78D over the past year and have been a big fan of the 78D lens, and I do not use the 90D lens as much anymore. So the second is your neuroretinal trim. Now, the neuroretinal trim, the standard definition is your classical ISNT rule, which states that inferior is thicker than superior, nasal, and temporal. And whenever there is a violation, as in the example you see there, you could argue that this is a sign of glaucoma. However, the ISNT rule may not be followed or may not be very helpful when you are looking at cases of glaucoma which develop concentric atrophy. In such cases, you look at the fellow eye, and obviously serial exams will give you a better idea regarding glaucoma. Of course, another important parameter is pallor. As you can see, the picture on the right, there is a definite optic disc pallor there when it is corresponding with a lower visual acuity. You look at the visual fields, you should think about non-glaucomatous causes, and this happens to be an optic nerve meningioma. So Dr. Spaeth et al. Published this paper about a decade back. And if you look at the top picture marked as A, there are 2 large discs with large cup disc ratios. Interestingly, these are 2 discs which have been followed up for more than 30 years without any signs of glaucoma, whereas less dangerous appearing, more innocuous appearing discs, which are marked as B and C, actually turn out to be glaucoma. So an objective way of looking at this is to use something called as the disc damage likelihood scale, which basically measures only 2 things, disc size and the rim disc ratio, where you look at the thinnest width of the rim. And this will help you to stage a disc, and then you can basically think of a disc as having probable damage or definite damage. And it has been found that the disc damage likelihood scale is actually quite useful. In fact, the cup disc ratio has a very low correlation with glaucoma. It is the narrowing of the rim that has higher correlation, and multiple studies have shown that a disc damage likelihood scale is superior to the cup disc ratio and also as sensitive and specific as HRT2, and it has got very positive correlation with your pattern standard deviation in Humphrey perimetry as well. Coming on to the retinal nerve fiber layer. The normal retinal nerve fiber layer is best appreciated on your red-free, and you can see these as bright striations. And when you have these loss of striations, you will be able to pick up these RNFL defects best on a red-free. It's much easier to pick up the localized RNFL defects because you'll be able to appreciate the shadow and the contrast much better and it's a little more difficult when you have a diffuse loss. And these localized wedge-shaped defects have very high specificity for glaucoma, generally tends to be picked up in very early glaucoma itself, and preferentially gets located in the superior and inferior temporal regions. And there is some association of these wedge-shaped defects with low pressure glaucoma as well. And these wedge-shaped defects in normal tension glaucoma tends to be more wider and closer to the fovea than in your typical primary open angle glaucoma. In fact, there have been reports when in the presence of well-defined RNFL defects, the OCT was not able to actually show any significant thinning, but these defects can be very well seen on your red free. The disc margins, now the most important thing here is to look for disc hemorrhages. Now, disc hemorrhages can be transient. So it might be present on one visit and might disappear on the next visit. And detection would obviously require very careful optic disc examination. In a lot of landmark trials, it has been shown that unless an optic disc photography is done, if you're not specifically looking for disc hemorrhages, you can actually miss it quite easily. Now, a disc hemorrhage, as I said, can appear and disappear and can be a sign of an impending progression. As you can see here, a patient with no disc hemorrhage in July, after about 6 months or so, develops a disc hemorrhage on the temporal region. This hemorrhage increases in size and extent over the next month. And when it disappears, the field effect has also deepened and extended. Now, myopia and glaucoma. This is usually a big problem. Myopic discs tend to be tilted. It's very difficult sometimes to delineate the borders of the disc. They tends to be larger discs, larger cups, and the cups also tends to be shallow. And they generally, because of myopia itself, tend to have thin RNFL and RNFL defects. And when you see such myopic discs and you perform visual fields, and you can sometimes see these visual field defects, you have to look at other parameters, including your intraocular pressure, to actually understand this, because 5 years later, without treatment, this patient has no progression of visual field defects. It's very much possible that these defects are simply myopic and not glaucomatous. And this is further complicated by the fact that there are publications, especially large population-based studies, which shows that there is increased risk of glaucoma with myopia, while there have been some studies that also does not show this association as well, notably being the OHTS. And you have to be aware of certain conditions or discs that mimic glaucoma. When you have a superior segment optic nerve hypoplasia, which is symmetrically thin superior optic neuroretinal rim in the optic disc. And when you perform a visual fields, you will find an inferior arcuate defect, but these are hereditary conditions that do not progress. Now, we have to be aware of the various structural anomalies which can be present congenitally, like your morning glory syndrome, your inferior optic disc colobomas and optic disc pits. Only if we are structurally aware of these particular morphology can we actually pick them up on your first visit itself. And I'll finish off the presentation with a couple of case examples. So a myopic disc, we see a visual field defect. If other parameters are within normal limits, I think there is a good argument that we can wait in such cases before jumping the gun and starting treatment. On the other hand, if you see a disc like this on the right-hand side, you can see that there is an RNFL defect, there is a whiff of disc hemorrhage there, and there is focal notching. And if you go back and apply your disc damage likelihood scale, this would come in a situation where the patient is in stage 4, that is definitive damage. And therefore, even if the visual fields are only showing in the right-hand side an evolving nasal step, I would be completely comfortable starting treatment for this patient. Thank you.
Thank you, sir, for that excellent talk. Shall we keep the discussion towards the end?
Yeah, sure. No problem.
The next talk, allow me to invite Dr. Gauri Murthy to talk on OCT interpretations.
Gauri, you're muted.
Dr. Gauri, you're muted. Dr. Gauri, you are muted.
I'm sorry. Yeah. I'm sorry for that. thanks to the Cochin Ophthalmic Society, Dr. Ronnie and Dr. Aditya for the invite for me to speak on OCT in this meeting. So what does the OCT do when we are looking at detection of glaucoma? Essentially, it measures the retinal nerve fiber layer's thickness. How does this do it? It measures the retinal nerve fiber layer in a measurement circle around the optic disc, and it segments the RNFL from the other layers, and this thickness is compared to age-related normals and the fellow eye. It also measures optic nerve head parameters, mainly the neuroretinal rim width. We also now look at the macular and the ganglion cell layer thickness, as we know that death of the ganglion cells leads to macular thinning, which can be localized or diffuse loss. And localized loss can be correlated with changes in the peripapillary RNFL and visual field effects, like you can see over here. So let's look at the step-by-step interpretation of the glaucoma OCT in the commonly used machines that are in use today. So the first one is the Cirrus Spectral Domain OCT. So this is the typical printout that we get. So just like we do a sequential analysis in a visual field, the OCT printout is also to be approached in a same systematic manner. So first look at the patient details if everything has been entered correctly. And then the next important thing is the image quality. If it is not a good quality image, then all this may not be accurate and should be thrown into the waste basket. So image quality here is 6:7 or 8:7. So anything which is more than 5 in the Cirrus OCT is considered as acceptable, but higher the image quality, the better. And next you go to this sector, which you by and large ignore when you get the printout. Why is it important to look at this sector? You should look at the tomogram landmarks and the segmentation accuracy. So you can see here, the tomogram and the segmentation lines are indicated here. And the optic nerve head, the edges are also marked over here in these cross sections. So if there is any inaccuracy in this, then whatever analysis is there in the other two color-coded images is unlikely to be accurate. So it is important to look through this as well. After this, we go to the color-coded Rnfl thickness map. So this is the color-coded Rnfl thickness map. And you can see these hot colors in the superior and inferior sector, the typical Rnfl bow tie. And the deviation map tells you where the Rnfl thickness is less, or the deviation from the normative database. So you can see that there are areas of Rnfl thickness decreased in both the superior and inferior Rnfl areas. And this is like a wedge Rnfl defect. And there are these two Rnfl defects here superiorly. And in the left eye, again, you can see a similar picture. So once you look at this, then you can look at the disc and the NFL parameters. So these are these numbers which are again color-coded according to the normative database. Red is a very significantly abnormal value according to the p-value which is there compared to the normative database. Yellow is borderline and green is normal. You don't pay actual attention to the numbers. You just look at the color code and look at which aspect or which parameter is grossly abnormal. After this, you have the Tisnet curves for the neuroretinal rim and the Rnfl thickness. So this green area is a normal thickness, the yellow is borderline, and the red is abnormal thickness. So wherever your curve goes, so if it is entirely in the green, that means it's normal. When it dips into the yellow or in the red, it means it is abnormal. And then you have quadrant-wise and sectoral examination of the NFL thickness and clinical correlation. So this is how you go through a OCT printout. After this, you can also see the macular scan if it has been done. And this kind of a donut-like appearance, and the thickness is mentioned here in sectors. This is what you see in a normal eye. So another example, this is a Cirrus printout where both in the right and left eye, you can see that there is absence of the hot colors in both superior and inferior. There is only one area here and one area here. So there is actually significant loss. And you go to the segmentation and the tomograms here, looks quite okay. And you go to the deviation map, you can see that predominantly there's an inferior Rnfl loss and some superior Rnfl loss as well. Both extensive superior and inferior Rnfl loss in the left eye. All the parameters are marked in red. That means that this patient has a very significant decrease in the Rnfl thickness globally. And the neuroretinal rim thickness also largely falls into the red, as well as the Rnfl thickness. And there's only a little bit of the superior hump preserved, and the inferior hump is actually almost flattened over here for both the right and left eye. So the sector-wise analysis also shows the same, and the quadrant-wise and sector-wise analysis also give you more information about this. So when you look at the macular thickness, again, you see there is loss of the hotter colors here. And the deviation map shows there is loss of macular thickness, which correlates with this extensive loss which we saw over here. And similarly, in the left eye, more so than the right eye, which is also the pattern that we see in the Rnfl thickness. So you have to put everything together. Let's go to the spectralis. Here again, you look at the signal strength, and scan quality affects ocular OCT performance even when it is within the manufacturer recommended limit. So you should look at the scan quality, and its effect is greater on the Rnfl than on the optic nerve head and the ganglion cell complex. So the minimum acceptable signal strength for spectralis is at least 20. Here it is 29. So that is okay. And then again, we should understand that the machine automatically detects the BMO, that is the Brooks membrane opening. And based on that, the neuroretinal rim is analyzed. Anything, this automatic detection of the BMO is done by 24 scan lines across the disc, radial scans. And this is how the disc is assessed. So it is important to understand how this happens. When we have a large disc, you will have false negatives. When you have a small disc, you will have false positives. So larger discs have lower sensitivity for early glaucoma, and smaller optic disc size are associated with OCT Rnfl false positive. So let's look at a few printouts again. So this is a patient. The segmentation is good. The quality is 29, which is quite good. And this is the red-free image. There is a certain amount of movement of the patient, but then this is a well-centered image, and the disc is well-centered in the calculation circle. So let's look at the Tisnit graphs. This is for the Rnfl, and this is for the minimum rim width. And you can see that the Rnfl, just a second, the Rnfl thickness is largely within the green zone. And there is just this one area where it goes into the yellow zone, but then the double hump pattern is well preserved. And if you look at the minimum rim width, here you can see that the curve is dipping into the red zone just about in the nasal and nasal inferior sectors. And the same thing is reflected in the sector map. The Rnfl is largely normal, whereas the MRW, that is the minimum rim width based analysis, marks out the nasal inferior quadrant as abnormal. So why is this happening? Of course, I would definitely recommend that you go back, look at the patient, look at the disc clinically, look at the fields and see if there's anything correlated in this. But if you look at the optic nerve head, here you can see BMO area is 1.89 millimeter square. So this is the disc area. So this is a slightly smaller disc, and maybe because of that, this erroneous depiction of the rim and the disc analysis is there over here. Very important in such cases where there is a confusing discordance here. Look at the clinical picture and look at the visual field. The macular thickness here is quite normal. So inaccurate BMO detection by the machine can influence the MRW calculation. Here you can see that the BMO has gone way beyond the disc margin. And these two sectors are marked as abnormal, and this disc margin is coming inside the disc. So this the BMO has been marked inaccurately. So you should go and you should confirm and correct the BMO by going through each of the scans. And once you have done that and now see the BMO is marked correctly, each scan you select and you modify the BMO, you can see that all the sectors became normal, which is what it was clinically. So it's not just the printout, you need to go back to the machine and look at the actual scans and look at where things could have gone wrong. Another printout, here the segmentation again is normal. And if you look at the Tisnit graph, you can see that the superior temporal Rnfl is low, and also the inferior temporal Rnfl is low in this eye. And the same thing is maintained even in the rim detection, and more so in the superior quadrants rather than in the inferior quadrants, which is what you will see in these sector-based maps. So if you look at the macular thickness here, you can see that correspondingly, because the superior is the one which is lost more, you can see that the macular thickness here in this sector is also reduced. So this is how everything is put together. This patient has definite glaucoma, and the superior neuroretinal rim loss and Rnfl thinning is more. The inferior is slightly lesser. And there is an effect here, but not as much as in the superior macular area. So this patient has clear-cut glaucoma, but again, correlate with the clinical findings. Another patient, so this is just the Rnfl thickness. You can get various types of printouts from the machine. You should preferably get both Rnfl and the disc analysis on the printout. In this printout, it's just the Rnfl analysis. Here you can see segmentation is okay, but you can see that there is a predominant inferior Rnfl loss, and you can see the macular thickness also in this sector is quite reduced. So all of them, and even this hemisphere asymmetry shows a predominant inferior Rnfl loss. This again is a clear-cut patient of glaucoma. So let's look at this patient. This is a patient who came for a routine eye checkup, and we picked up something clinically and therefore subjected him to the glaucoma analysis by the OCT and visual fields. So what is happening over here? Quality is 30, Rnfl all green, rim all green, sectors all green, both Rnfl and rim. Macular thickness quite normal. So this patient must be normal, right? But then what's happening over here? See, you can see that there's a clear-cut Rnfl effect, which we could pick up clinically. We didn't need a machine to do that. Why is this not being picked up on the machine? So let's look at the Rnfl analysis map. So this is the segmentation. It has been done properly, but you can see that, yes, in that area where there is Rnfl thinning, you can see that this is actually just dipping into the yellow. But because of the averaging in this area, this whole sector has been depicted as green. If you just move the calculation circle a little outward, you can see that the graph dips into the red and this sector is marked as abnormal. So you should always clinically correlate, and you should not take things at face value. So never ever assume that the OCT is better than you. You are using that. It is a tool in your hand. Again, here, the Rnfl and the rim are marked in green, but you can see there is a clear-cut Rnfl defect over here. Here, the macular map gives you a clue. See, there is a gap over here, which correlates with this Rnfl thinning. So this patient has again clear-cut Rnfl loss. And if you go by just this green, you will be disappointed, you will be wrong, and you will not be treating a patient who actually has glaucoma. Incorrect segmentation is a very, very common error in OCT, especially in myopic eyes and tilted discs. Here you can see that this thing is going inside the Rnfl, this segmentation. So there is an incorrect anterior segmentation of the Rnfl. In this, there is an incorrect posterior segmentation. See, the Rnfl end is somewhere here, whereas the machine is calculating it to be here. So that is why the Rnfl thickness is going into the red zone. So here there is incorrect segmentation. So what I would like to tell you is that the OCT is a tool in your hands. Look at the patient, look at the other diagnosis, the fields, and then correlate it with the clinical picture. And if you rely more on these red values to declare glaucoma, it is unfortunate. It is a disease that we have, not the patient has. And therefore, it is very, very important to put this OCT or this red into the clinical context and look at what actually is happening and whether things are really abnormal. So think, the OCT machine does not have a brain, so you need to use yours. In summary, pay attention to image quality, look at segmentation errors. Whenever possible, go back to the machine, look at the images and look at whether things have been calculated properly. Take into account the disc size, integrate the findings from the disc, the neuroretinal rim, the Rnfl, and the macular GCIPL. Go back to the machine, as I said, to reconfirm images when in doubt and correlate with the other clinical findings. Thank you so much.
Thank you, ma'am. Thank you for the wonderful presentation. Next, we move to the next topic, that is classification management of primary angle closure disease. Over to you, Arun, sir.
Hello, everyone. Am I audible?
Yes, sir.
Thank you. Thank you, KSOS. Thank you, COC. I'll be speaking on primary angle closure disease, classification and management. No financial disclosures. The traditional classification for PACD has been to use the terminologies acute angle closure glaucoma, subacute angle closure glaucoma, and chronic angle closure glaucoma. Now, these categories were evolved from a set of ad hoc clinical observations. It did not really reflect a natural course of disease, and it did not consider the extent of synovial closure or optic neuropathy. Everything was labeled glaucoma. There was a significant overlap in the clinical presentation and did not guide towards a logical management plan. This is where the ISG or nomenclature focused on three conceptual stages in angle closure. It started off with the extent of iridotrabecular contact, included the presence of raised intraocular pressure, synechiae, glaucomatous optic neuropathy, and in general, it was largely designed for use in prevalence studies and epidemiological research. An adaptation of this is now a standard in clinical practice, and we have three categories of primary angle closure disease, namely the primary angle closure suspect, EACS, EAC, primary angle closure, and the primary angle closure glaucoma. Now let us look at the criteria for each of these categories. Primary angle closure suspect is essentially defined when you see iridotrabecular contact on gonioscopy that is 180 degrees or more. There is no evidence of any peripheral anterior synechiae on indentation. The intraocular pressure is normal with a healthy optic disc, and the visual field is normal. Primary angle closure, on the other hand, has angle closure iridotrabecular contact that is 180 degrees or more. There could be some peripheral anterior synechiae on indentation or could raised IOP. A combination of both could also exist. It's important to note that the disc remains healthy and the visual field remains normal. Primary angle closure glaucoma essentially means there's glaucomatous cupping with a visual field loss and a narrow angle. Intraocular pressure could be raised or need not be raised. There could be synechiae or no synechiae. So just to recap, primary angle closure glaucoma has glaucomatous cupping with visual field damage. Primary angle closure has raised intraocular pressure and peripheral anterior synechiae. And a key to categorize these patients is to be well versed with 4-mirror gonioscopy, and your ability to do indentation gonioscopy is extremely important to categorize these patients. Essentially, these categories have helped differentiate true disease compared to suspects, and also the term glaucoma is reserved for people who have had damage to the optic nerve. Now, any of this spectrum can go into an acute angle closure crisis. So this is a good time to look at how we manage acute angle closure crisis. I give you a broad overview and a picture of what is the current standard for managing acute angle closure. In terms of diagnostic criteria, we need the presence of at least 2 of these symptoms: pain, nausea, vomiting, history of subacute symptoms. The intraocular pressure should be raised, and presence of any of the 3 following signs like conjunctival injection, epithelial edema, a mid-dilated non-reactive pupil, shallow anterior chamber, and a closed angle on gonioscopy. Now, the goal of treatment of an acute angle closure crisis is to lower intraocular pressure as quickly as possible, achieve symptomatic relief, reduce the risk of irreversible damage to the optic nerve head, prevent recurrent attacks, and retard progression to chronic disease. Now, how do we go about this? We need to achieve intraocular pressure reduction by all the medical therapy that we have access to. Once we achieve intraocular pressure reduction and corneal clarity, the next step would be to perform a laser iridotomy. A very important aspect to focus on would be the fellow eye, which is likely to be closed as well. And this is the current standard of care. Now, there are a few alternative approaches, such as the peripheral iridoplasty and paracentesis. Typically, peripheral iridoplasty is indicated when the corneal edema is significant and a laser PI cannot be done safely. However, we need to remember that it does not eliminate pupillary block, and a laser PI would be required at a later stage. Paracentesis is reserved for extremely rare situations where you have a lack of access to immediate laser. It's a very challenging procedure in a symptomatic patient and is fraught with a high risk of complications. An important aspect to review here is the role of lens extraction in acute angle closure. The aim of lens extraction is to relieve pupillary block. Literature documents a significant relief with the decrease in angle crowding following lens extraction as expected. Intraocular pressure control without medications has been reported to be in the range of 60 to 70%. It may also help resolve non-pupil block components, if any. There have been two publications that I would like to review here. One is by Jacobi and group, wherein they compared primary phacoemulsification in acute angle closure versus surgical iridectomy, and they reported an intraocular pressure control of significantly higher proportion in the phaco group and lower proportions in the phaco group required additional surgery compared to the iridectomy arm. Dennis Lam and group have also published a group of 30-odd subjects wherein they were randomized to phacoemulsification versus a laser iridotomy for acute primary angle closure, and they reported that the LPI was 15 times more likely to have an intraocular pressure of more than 21 compared to the phaco eyes, and the LPI group required more medications to control IOP at about 18 months. Now, what are the collateral damages that can occur? They can be significant. They reported significant corneal edema, posterior capsular rents, fibrinous reaction, and early PCO. So it is quite challenging to do a phacoemulsification in a very hot eye. Needs a significant amount of experience and skill if you opt to choose this route. Moving on to the further course in acute angle closure, once the intraocular pressure is controlled, we need to monitor and tailor the medical therapy and opt for a cataract surgery when it's visually significant. Let us say the intraocular pressure is uncontrolled and eye is quiet. Your next step would be to do an indentation gonioscopy and to assess the lens status. And once you've assessed the extent of angle closure, if the peripheral anterior synec is below 180 degrees and the lens is clear, you opt for a trabeculectomy. If the cataract is significant, opt for a staged phacoemulsification, and if required, a trabeculectomy at a later stage. If the synechial closure is greater than 180 degrees and the lens is clear, one opts for a trabeculectomy. And if the cataract is significant, we opt for a phacotrabeculectomy. This is a good time to review the natural history of angle closure. In general, the literature we have from our population suggests that the closure rates are progression rates in angle closure suspects about 22% over 5 years to angle closure, and angle closure to glaucoma is about 30%. And new data from this part of the world, this suggests a very low conversion rates of between 5 to 10%. So the laser iridotomy for primary angle suspects, based on the background we know of a low rate of progression in these subset of eyes, essentially means that not all subjects with the ACS need a laser PI. They can be observed with periodic gonioscopy. Some of the absolute indications for a laser iridotomy are the narrow angles in the fellow eye of acute angle closure, confirmed family history of primary angle closure glaucoma, a clear history of subacute symptoms. A few other indications are patients who need frequent dilatation for retinal evaluation, such as in diabetics, patients who have poor access to medical care, and only-eyed patients. And in general, eyes with narrow angles and a visually significant cataract should be recommended for early cataract surgery. Moving on to primary angle closure, laser iridotomy is the crux. That is the first stage of managing and evaluating these patients. Once we've done the laser iridotomy, a gonioscopic assessment would be your next step to assess the extent of angle opening that you have achieved. And following this, depending on the intraocular pressure control, one opts for a phacoemulsification for a visually significant cataract. And let us say the intraocular pressure is uncontrolled on medical therapy. We need to move on and evaluate the eye further, do an indentation gonioscopy, and evaluate the extent of synechial closure. Let us say, and further steps that you need to look into is the status of the lens. So let us say the indentation reveals synechial closure less than 180 degrees and the significant cataract. One can opt for a phacoemulsification. In the absence of a cataract, a laser iridoplasty is an interim option before you head to a trabeculectomy. In the presence of extensive synechiae and a clear lens, one should opt for a trabeculectomy. On presence of a visually significant cataract, and a phacotrabeculectomy would be a reasonable option. Primary angle closure glaucoma is managed very similarly as the primary angle closure in the initial stages. And when we move on to the category of subjects wherein the intraocular pressure is uncontrolled, despite the laser iridotomy and medical treatment, you need to go back to your basic principles of doing an indentation gonioscopy and assessing the lens status. And again, based on the presence of synechial closure and the lens status, you opt for a phacotrabeculectomy in the presence of a significant cataract. And in the absence of a cataract, opt for a trabeculectomy. You need to note that these are glaucomatous eyes, and hence you need to have a lower target of intraocular pressure, and thereby phacotrabeculectomy becomes an option or the choice, the route of choice to adopt when you are encountering uncontrolled intraocular pressures in this group of patients. Clear lens extraction for PAC and PACG, the outcome is available to us via the EAGLE study, and they essentially randomized about 200 subjects in each arm. And the outcome of the study at 3 years did report a mean health score that was marginally higher in the lens extraction group, and intraocular pressure again about 1 millimeter different compared to the iridotomy eyes. Significant amount of limitations with this study is the minimal IOP reduction. The gonioscopic data, especially the extent of silent field closure, was missing from the case report forms in a significant number of patients. Most of these patients had early to moderate glaucoma. The loss of accommodation from this intervention can be a significant handicap which we need to think about. And the outcome was largely reported in Caucasian and Chinese subjects from this study, and it would be hard to extrapolate and adapt any of these results to our population. So to summarize, the spectrum of angle closure is more well-defined now. The newer classification adds more structure to assessment and management of PACD. The mainstay of managing primary angle closure and primary angle closure glaucoma is a laser iridotomy with medical management. A detailed gonioscopic assessment before and after laser PI is crucial. Further management depends on the extent of BAS, glaucomatous damage, and the presence of a visually significant cataract. With that, I'd like to thank and share some suggested reading. Thank you.
Thank you, sir. Thank you for detailing all the different ways of managing angle closure disease. Now the forum is open for discussion. So Kiran sir, I have a question for you.
Yeah, go ahead.
Many times this myopia and glaucoma is the most tricky part.
Yeah, it's quite tricky, not only in terms of disc evaluation, which is what I talked about. Also, if you look at the visual fields, if you want to perform an OCT, everything, you can actually have a problem in distinguishing simple myopia and glaucoma. So obviously you cannot rely on a single parameter, and you cannot simply start treatment of a patient based on the fact that the patient has a visual field defect. Some people say that, okay, there are some characteristics of, say, myopic visual field defects, which are slightly different in the sense that there tends to be more localized and tends to be more sharper than a glaucomatous defect. But these are probably differences in observation that is very difficult to actually make a final decision on. So that is why there is always going to be a confusion. And I suppose one has to make a judgment call, and we cannot clearly say if a patient who is myopic has glaucoma or not. Obviously, if you have other associated features like a raised intraocular pressure, that's an important factor. But otherwise, it's very difficult. And plus, it is complicated by the fact that myopes are at increased risk of glaucoma. So there is a very good possibility that a lot of myopes that one treats for glaucoma tends to be overdiagnosed for glaucoma.
But generally, we all tend to have a low threshold for starting treatment when there is a suspicion of glaucoma in myopic patients. Am I correct?
Yeah, I think that is correct with respect to glaucoma specialist, Dr. Manoj. But then if you look at general ophthalmologists, the way we see glaucoma is most often missed in myopes. You see these patients when they have already got advanced, field loss and disc damage. And that's because it's so difficult to pick up. Unless you're looking for it, you won't pick it up. So I would say glaucoma is missed in myopes rather than overdiagnosed. Others may beg to differ.
Can I add something?
Yes, sir.
The thing is, myopia is a big nightmare for us to diagnose glaucoma because a lot of features are there because of myopia. The only time we can really be sure is when we actually document their progression. Yeah. And to make matters worse, the myopes who actually have glaucoma progress much faster than the rest of our glaucoma patients. So it's a tightrope that we're walking. So I would tend to do a couple of fields in rapid progression, rapid repetition before I label somebody as a glaucoma if the IOP and everything else is not fitting fully to a proper glaucoma. But I agree, we need to be more vigilant and more aggressive when we treat myopes and glaucoma.
Yeah, I second what Dr. Gauri said. It may be missed by general ophthalmologists. In my case, personally, I tend to actually watch these fields closer before jumping into treatment. And, because a lot of patients I have once treated, and subsequently I have had to stop treatment at one stage of my career. So I actually watch their fields closely, and I would say that a progressive visual field loss is probably the definitive sign there that we are dealing with glaucoma, but because every other test can be kind of confusing.
Even progressive maculopathy can also happen in myopia. That is another thing that is confusing. The field can also deteriorate with the maculopathy changes.
True.
So is there a difference in the disc examination findings in PSEG and POAG, or is it all
Oh, the difference on the disc? I don't know. I really don't know. I think that once the intraocular pressure damage sets in, the differences should not be there on an optic disc evaluation. I don't know if there are some theoretical tidbits on some textbooks, but I don't think there is any. I mean, you cannot simply look at the optic disc and say that this is a angle closure glaucoma, this is an open angle glaucoma. No.
But having said that, what you said is 100% correct, Dr. Kiran. But in angle closure, when you have had an acute raise in pressure, like the pressure has gone up to 40 or 50 and then come down, you will have pallor of the rim. And that is an indication that the pressure has gone up really high. And also more shallow sort of a cupping. So this is some things that we can see. So the pallor of the remaining rim is something that you can see in any eye which has undergone an acute raise and then decrease in the IOP.
Okay.
Dr. Sai, you want to ask something?
Yeah, my question is to Dr. Narayan Swami. See, about 10 years back, this is basically based on the natural progression of PSEG. About 10 years back, we were sort of in a lot of studies from North India, which told us that the number of angle closures in Indian eyes is much more than the Caucasian eyes, and we sort of tended to do more and more PIs in the angle closure suspects. And with this new Chinese study which has come up, which says that probably the natural progression is not that much. I mean, what is the current status? Do we just follow the guidelines, or what is your what do you do in clinical practice, Dr. Arun?
I think we have two experts who have published this incidents from Singapore. Bhaskar will probably give us more information. And in terms of based on the data from Singapore and China, I don't think we can extrapolate it to our group of patients. So I would still follow a very conservative approach of what I outlined at the top, that most primary angle suspects can be observed. Anybody with conversion or progressing needs to be treated, development of subacute symptoms, or I would stick to the guideline of subjects requiring frequent dilatation and subacute symptoms. Overall, I think the number of laser iridotomies, which even I have been personally doing, have reduced after looking at these very fair and logical guidelines.
What would be your recommendation for the gap between visits? I mean, how frequently would you perform a gonioscopy?
Yeah, I would stay with ideally every year, especially once you've diagnosed baseline primary angle closure suspect. But it depends on your practice environment and the logistics. Even nowadays, we've been, in fact, some of my patients we are seeing straight away once in 2 years because of the logistics. But yeah, a gonio at least once in a year or once in 2 years would be a reasonable option to adopt.
I'll just add one thing over here, and that is basically one of the reasons why the Singapore and the Chinese study found much less angle closure progression is because the definitions for progression were different. They required half a clock hour of Sine K for progression, while both the studies out of WWOR required just a single pinpoint peripheral anterior Sine K. And that is the reason for the difference. It's not that, I mean, when your outcome is defined differently, you will find different rates.
Welcome, Dr. Rajul. I think Dr. Rajal has joined.
Yeah, he has joined and he will be part of the next sessions. So Arun, you briefly said that, I mean, you and Bhaskar both have a lot of experience looking at Chinese eyes too. So do they behave differently from Indian angle closures?
I would very much say so, because the kind of indentation you need to do to evaluate the extent of synovial closure is fairly challenging in Chinese eyes. The way they are crowded is quite different. Many times I am not able to indent and see the posterior trabecular meshwork technically, but they don't have synechiae, and you pick that up only post cataract surgery. So the amount of anterior segment crowding and the way they behave in terms of evaluating or to indentation or response to indentation is quite different. I would like to hear from Bhaskar.
I agree. One of the reasons is because of the large lens they tend to have compared to our eyes. They have more higher lens vault. And second, these eyes tend to get quite a bit inflamed in acute angle closures. Their acute angle closures are a bit difficult to manage actually. And the third thing is, there tend to be more myopes with angle closures as well. In Singapore, that the myopia incidence, prevalence is quite high. So these three differences are there. And otherwise, I think general management tends to be the same. I agree with Ronnie about the definitions. However, I think overall, the WWOR study was conducted in rural population, and maybe there are some differences between rural and urban population of India itself. So overall, asymptomatic PACS patients tend to progress less to the next stage. But rest of the PAC and PACG, we need to be aggressive in treating.
One of the authors of the WWOR study is disagreeing on something. He's waving his hand.
WWOR eye survey was not on a rural population. It was on an urban population. Now WWOR is a city. It's a major city now. The mistake that we made on WWOR eye survey was, one, we restricted our population age group because we were looking towards a incident study later on. So we just saw the 30 to 60-year-olds at the time. And the huge mistake there was when, it's only when I looked at the final analysis, all I needed to see was another 100 patients to see the whole population, which was, looking back at it, it was stupid, but then, by then it was too late. Two is that all these classifications have come in after the WWOR eye survey because we were the ones that kicked off. In fact, it was my laziness that we never published before Paul Foster, because we had everything ready, just the writing up and deciding where to send it, because there was a lot of politics at that time with Hyderabad and Arvind also doing papers, and we were seriously worried whether these major journals would block publication. So which is why one of the main reasons why we went for the Indian journal straight, because if we had sent it to either of the big journals, it probably would have got blocked because they all had their money in the other studies.
I have one question, Dr. Arun. All these studies which look at treatment of acute angle closure crisis and you perform phacoemulsification, what is very, I am not sure if I am missing something here, because the phacoemulsification is done after you have started the patient on medications, achieved some corneal clarity. So what would prevent us from first performing an iridotomy, and in most cases, at least in 50% of cases, I think they should respond with an iridotomy. And then if they don't respond, go ahead and do a clear lens extraction rather than choosing clear lens extraction as the primary strategy, which is fraught with, quite a few risks.
Definitely, the approach is challenging. The other reason why they explored this was iridotomy, like we said, in the Southeast Asian population is quite challenging, of course, for many reasons, apart from being the acute attack. And the technique used for iridotomy is a combined organ YAG technique, and that is known to cause late corneal decompensation. So they probably were looking at a single insult episode rather than a dual insult episode of an iridotomy followed by a traumatic cataract surgery as well. So that could be the only thought process that can explain as to why they decided to explore doing a phaco in a very difficult eye. Yes, nothing like achieving an iridotomy, quietening the eye down, and taking care of. In fact, you can assess even gonioscopic assessment and presence of synovial assessment is very challenging when the eye is inflamed, the iris is boggy. Whatever indentation you do, you're not correct with your extent of synovial closure. So the ideal approach is to achieve an iridotomy possible, or at least quieten the eye down before you do the LEGZEC.
I think Abhilash and Thomas both want to make a comment. Abhilash, you want to ask something?
Yes. My question is towards Dr. Kiran.
Yeah, sure.
Regarding the disc damage likelihood score, how often do you use it? How practical do you find it?
Actually, it's not like I stage every disc using a disc damage likelihood scale. There was a point when I actually read about the disc damage likelihood scale that I was actually staging every disc based on that. And it was actually not very difficult. It's quite easy once you get a measure of the optic disc size and the rim disc. Because only 2 parameters you require to do. I don't do it on every case. It's just at some point in my learning curve, I was using it regularly to see how much it actually kind of relates itself to our final diagnosis, and it correlates quite well. And it's not very difficult. It hardly takes a minute or so to actually stage a person with the disc damage likelihood scale.
Yeah, I think, thanks. We have a suggestion from the chair to move it forward.
Yeah, we are running short of time.
5 more talks to go. So I'll just introduce the speakers in the next session, and thank you for taking care of this. Aditya has already been introduced, and just like to say that he's also a passionate teacher, and he was very, very popular with all the Glaucoma fellows and postgraduates when he was with us, because he had the patients visit and teach them. Dr. Deepa is joining us from Atlanta. She's an associate professor at Emory. She did her MD and MBBS from the All India Institute of Medical Sciences, and a fellowship in corneal physiology and pathology at Emory, a glaucoma fellowship at the University of Nebraska, followed by and her ophthalmology residency at the University of Kentucky. Her research work focuses on the impact of visual disability on the activities of daily living, particularly driving, visual perception, and ocular disease, and biomarkers for CNS disorders. Her clinical work focuses on adult and pediatric glaucoma, and today she will be speaking to us a little later about Netacertin, on which she has actually worked and published. The third speaker in this session will be Dr. Rajal Parikh, my good friend and director of Shriji Eye Clinic and Palak's Glaucoma Care Center. He was an associate advisory board member of the WGF from 2005 to 2018. He's the society editor of the IGR Review since 2018. He's a member education committee of the WGA2. He used to be the glaucoma section editor of the IGO for 6 years, and he has over 80 publications. He has contributed to the World Glaucoma Association consensus books, and is a popular teacher in this country. I'll hand it over to Dr. Abhilash to take the session forward.
Thank you, sir. We'll first go over to the basic visual field interpretation by Dr. Kenyo. I'd like to introduce, I'd like to invite him for his presentation.
Good evening, good morning. Are my slides visible?
Yes.
Yes. Thank you to Cochin Ophthalmic Club for this opportunity. So basically, we'll just look at basic visual field interpretation in this presentation. So this is the trapezoid hill of vision, which we all know, with the fovea having the highest sensitivity and going periphery having lower sensitivity, with the blind spot temporal to the fovea. So in this presentation, we will basically look at how to interpret a Humphrey visual field printout. And this talk is based on this very good article from the Indian Journal of Ophthalmology by Dr. Ravi Thomas and Dr. Ronnie here on interpreting automated perimetry. So this automated perimetry printout has a lot of data, a lot of statistical data, which basically the machine takes the patient's measurements and compares it with the age-matched normal. And so this has to be looked at systematically, stepwise way, so that we do not miss any feature. So coming on to the first, we look at the patient data, then we look at the reliability indices, then we look at the grayscale, then comes the total deviation plot, then the pattern deviation plot, then we go on to look at the global indices, the glaucoma hemifield test, and then we can look at the threshold values if required. So coming on to the type of test, the Humphrey perimeter has both screening test library and a threshold test library. But for glaucoma diagnosis and follow-up, we use the screening test, which can be either a 30-2 or a 24-2. In the 30-2, 76 grid points are checked in the central 30 degrees, and 24-2, 54 grid points are checked in the central 24 degrees. These points are each 6 degrees apart. And apart from that, we have a 10-2 and a macular program, which looks at the central 10 degrees and the 5 degrees. And in this two programs, the points are very close, only 2 degrees spacing, so any small defect can be picked up. And in the macular program, each point is checked twice. So coming on to the printouts, this is the printout of the right eye at 30-2. The eye is written here. And this is a left eye of a 24-2. So in a 24-2, 24 degrees of the field is checked, but nasally it is checked till 30 degrees so that any early nasal step can be detected. The stimulus size used in standard automated perimetry is size 3 and the stimulus color is white. Very important that we ascertain the correct age is entered, the date of birth is entered, because this is required for the machine to calculate the age-matched normals. Then comes the pupil diameter. It can be done both dilated or undilated, but the most important is when we do a follow-up, the pupil size has to be consistent. We look at the visual acuity and the foveal threshold. Both should correlate. If the foveal threshold is low with a good visual acuity, there might be some foveal pathology also, early foveal pathology. We should check whether the proper glass correction is given so that there is no artifactual decrease in the visual field. So what is this threshold that we speak of? So threshold is basically at a given point, the intensity of the stimulus that is seen 50% of the time. That is known as the threshold. So the Humphrey visual field used the full threshold strategy initially, in which each point was tested by a bracketing strategy. And this is not used nowadays because it takes a long time. So in its place, the SITA or the Swedish interactive thresholding algorithm is used, which uses mathematical modelings to reduce the testing time. So the SITA standard is the regularly used program as far as glaucoma evaluation is used. Then we have the fixation targets going on to the zone 2, which is central, small diamond or large diamond. Basically, the central fixation is a yellow light, which is given in the majority of patients. But if there is a macular pathology and vision is very poor, the patient is not able to fixate at a single light, we can tell them to look at the center of these 4 lights. This is the small diamond or the large diamond if required. This is only required in patients with very poor vision. Then fixation monitoring is done using the blind spot method, the Hale-Krakow method, in which a stimulus is periodically presented to the blind spot. And if the patient is fixating well, they will have no response. The perimetrist can observe using the camera, and also the gaze tracker, in which an infrared light keeps tracking the corneal and the pupillary reflex. And instances of fixation losses are shown as the upward spike, and a blink is shown as a low downward spike. The gaze tracking graph comes at this lower part of the visual field. The reliability indices, the fixation losses are flagged if it is more than 20%. And another reliability index is the false positive error, in which the patient is trigger happy. Basically, the machine pauses, and if there is no stimulus projected, if the patient presses the buzzer, it is known as a false positive. False negative is another reliability index in which a suprathreshold or very bright light is stimulus is shown, and if the patient does not respond, it is a false negative. This can be due to fatigue, inattention, malingering, or even in severe glaucoma, this can happen. So these are also flagged if they are more than 33%. So the grayscale basically is to look for any specific patterns. You should not make a diagnosis based on the grayscale. You can discuss with the patient, but sometimes some very obvious patterns like hemianopia and other things can be picked up easily looking at the grayscale. Then we come back to our hill of vision, in which basically the yellow line depicts the normal hill of vision, while the gray area is the depressed hill of vision with a dense scotoma here. So the total deviation plot will basically reveal this depressed field, but the hidden scotoma will not be revealed by this total deviation plot. So the total deviation plot is basically a point-by-point difference from the expected value of age-related normals. So basically, this is what is the total deviation plot. One can see a numerical value for each point, how much it is depressed from the age-matched normal, and also a probability plot, which is a graph which shows the p-value ranging from p less than 5% to p less than 0.5%. So now coming again to a hill of vision. So this scotoma is what is revealed by the pattern deviation plot. So this basically reveals any focal defects after adjusting for any overall sinking or elevation of the hill of vision. And as we can see here, this dense scotoma, superior scotoma, has been revealed by the pattern deviation plot, but in the total deviation, because of the generalized depression, it cannot be picked up. So then we come on to the global indices, which are basically information from all the tested points, which is reduced to a single number, and in which we have the mean deviation, which is derived from the total deviation plot. This is the weighted average from the deviations from age-matched normal, and this number will tell whether the how much it has deviated from the normal. Then comes the pattern standard deviation, which is the weighted standard deviation of all the differences of points from the mean. So it indicates the degree to which the numbers differ from each other, the roughness of the field of vision. This is short-term fluctuation, which we don't see nowadays because it was found only in full threshold testing, in which basically these 10 points were tested twice, and the intra-test variability is what is short-term fluctuation. Another global index, which is not again found, this is the corrected pattern standard deviation, again in full threshold only, which is nothing but the PSD, which is corrected for the short-term fluctuation. Then we come to the glaucoma hemifield test, in which basically 5 zones in the upper hemifield are compared with 5 mirror zones in the lower hemifield, and the asymmetry between the two hemifields is looked at, and based on that, 5 types of results may come: outside normal limits, borderline, generalized reduction of sensitivity within normal limits, or abnormally high sensitivity. And there is another index, the visual field index, which is a number from 0 to 100%. 0 indicates a blind eye, while 100% is absolutely normal. This basically summarizes the visual field as a percentage of age-matched normal, and this is derived from the pattern deviation plot. And it is centrally weighted, means the central points have more weightage as compared to the peripheral points, and so is supposed to depict the visual function better. So how do we diagnose glaucoma? In early glaucoma, we can use the Anderson and Patella's criteria, a cluster of 3 or more non-edge points on the pattern deviation plot in a location typical of glaucoma, all of which are depressed at p less than 5% level, and one of which is depressed at p less than 1% level, or a CPSD or PSD that occurs in less than 5% of normal fields, or a glaucoma hemifield test outside normal limits. So these tests are basically have to be repeatable. That is very important. So if we look at this field, this follows the Anderson's criteria. We have these depressed points, GST outside normal limits, CPSD also is depressed. A very important thing to keep in mind, if we look at 24-2 fields, all the points are included. There are no edge points in case of a 24-2 field. But it is always very important to look at the clinical picture. If we see a advanced glaucoma like this, or glaucoma optic atrophy, a 24-2 field may not give us any information at all because of the extensive field loss. In that scenario, we might need to do a 10-2, which will show us the details of the central vision which is remaining, and also maybe a macular threshold to look at the macular fields. But whenever we look at a field, it's very important to keep in mind that our pathology can be at any level, a retinal pathology or pathology at the visual field, pathways also can cause visual field defects. So whenever we look at a field, we should basically see how arrange the field as the patient sees. The right field is kept in the right side, while the left field is kept at the left side. And we can see there are some superior defects here and some nasal defects here. But when we look at the fields in totality, we can see there is a pattern. There is a pattern, there are defects here. And so we should do the appropriate field. In this situation, it would be a 30-2. And when we do a 30-2, we can see this is a quadrantal defect due to a visual pathway lesion. So that is why it is very important to look at the whole visual field in totality when we assess visual fields. Thank you.
Thank you, sir, for that very concise yet informative talk. It's very difficult to talk on visual fields in 10 minutes. We'll discuss the talks towards the end of the session.
Okay.
As of now, we'll go ahead with Netasudil, the new kid on the block. I'd like to invite Dr. Deepa Kate for giving this talk.
Thank you, Dr. Pillai and Dr. George, for the invitation. A great session it's been. I've learned a lot. My name is Deepa Kate. I work at Emory University in Atlanta, Georgia. And my topic today is an update on Netasudil usage in clinic. So in fall and winter of 2017, there was a mass cheer that was heard from all the glaucoma specialists in the United States. And that's because for years, as Dr. Singh told us, we had drugs that reduced aqueous production, we had drugs that increased uveous scleral outflow, but the only drug that really worked on the conventional pathway was pilocarpine. And now we had two new drugs that work on this pathway. Latanoprostene Bunod or Vyzelta is a story for another day. Today, I'll talk about Netasudil. I'll start with a brief overview of the mechanisms. I'll talk some about the RCT usage with this new drug and how it's used in clinic. So ROCK stands for Rho-associated protein kinase, and Netasudil, along with others, is a ROCK inhibitor. What these ROCK inhibitors do, as can be seen from this picture here, are work on the trabecular meshwork and Schlemm's canal. They reduce actomycin concentration, extracellular matrix production, increase the hole size really, and increase outflow through this network. AR13324, which is what's now known as Netasudil, also blocks NET, which is a norepinephrine transporter. The role of these NET inhibition in glaucoma is still yet to be elucidated, but we know that Netasudil blocks both the ROCK and the NET functions. It's worked well in the lab and in animals, and I won't go into those studies. There are excellent reviews available. I will spend some time talking about how these Rho kinase inhibitors work in humans. Human studies are important, not just because they're very interesting, but because they tell us how this new drug plays with others. We study aqueous humor dynamics a few ways. Fluorophotometers, as can be seen here, use fluorescein to measure the concentrations in different parts of the eye. And they're important to look at uveoscleral outflow and aqueous flow production. In fact, they're the only way we can measure this. Both these studies are from the Mayo group. The fluorophotometer study was done in 11 volunteers, normal IOP, found that the pressure decreased about 4 millimeters. The outflow facility, the conventional outflow facility increased, and there was no change in uveoscleral outflow, episcleral venous pressure, or aqueous production compared to the controls. The same group did another study, and this was using tonography, in which you put a weight on the eye and measure the outflow through it. This shows a pneumotonometer tonography. They use Schiot's tonography in 20 patients with glaucoma. They also found that the pressure decreased about 4 millimeter and the outflow facility increased. I'm going to spend some time on EVP because it's often reported that the Rho kinase inhibitors are one of the few drops that decrease EVP. And that's based on these study results right here. As you can see, the EVP did decrease in the Netasudil treated eye, but this group already had a higher pressure than the control group. And on day 8, if you look at the EVP difference between the two eyes, it was not statistically significant. What was statistically significant was when the EVP was compared to its original baseline. So this difference between the two groups is important. And if you can see in the vehicle, the EVP actually increased. So the EVP etiology can be taken with maybe a pinch of salt. But it does work in humans. These are the ROCKET studies, which were necessary for FDA approval, and compared Netasudil with Timolol. In ROCKET 1, there were 182 patients per arm. And actually in 2015, it did not meet the primary endpoint of non-inferiority because the cutoff was placed at 27 millimeters of mercury. Then we got the power of post-hoc analysis. When the cutoff was placed at 26 millimeters of mercury, Netasudil was found to be non-inferior to Timolol. And actually, if it was set at 24, it was found to be superior. That led to its approval. And over the course of time, the pooled all the ROCKETs 1, 2, 3, 4 were all pooled together, and that data was released in 2020. And those are fairly large numbers, and Netasudil does tend to work pretty well. About 3.7 to 4.8 millimeter IOP decrease, which seems to be similar to Timolol. However, what is not similar to Timolol is the side effect profile of Netasudil. Conjunctival hyperemia was found in nearly 54% of all people, along with corneal verticillata, which was kind of a new side effect for us with ophthalmic drugs, and subconjunctival hemorrhage. In this study, the rates of patients who discontinued drug because of side effects was fairly low. But as I'll talk to you later, this is different when it comes to clinic use of Netasudil. So these studies tell us what the efficacy of the drug is, and these are important. They're randomized controlled trials done under perfect conditions with perfect patients and who bear no cost of the drug. In clinic, what we need to focus on is effectiveness. That's the pragmatic use of Netadus. And to figure that out, we did a study where Dr. Gorgon, who was a medical student then, and Dr. Gagrani, who's a fellow, that looked at all our charts, a retrospective chart review from 2017 to 2020 in the University of Nebraska Eye Clinic, which is where I practiced for the last 7 years. This is data that's been sent to a journal, so it's unpublished yet. It's been presented previously. The IOP efficacy was defined as the IOP at the first visit after starting Netasudil minus the baseline IOP. So our patients were old, like many glaucoma patients. The average age was about 69 years. 41% were male, 74% were white. Primary glaucomas were seen in 60% of patients. Of these, incidentally, there were also childhood glaucomas and PACGs, and secondary glaucomas in 40%, then extensive lists of neovascular, uveitic, and all the other kind of glaucomas that we tend to see. So the first question we asked, if we write Netasudil, how many patients fill the prescription? And in our group, 17% did not fill the prescription for Netas. And 68% of this was because of cost. There's no generic available for this drug in the United States at present. I understand there's a generic available in India, and this might not be as relevant there. 23% of our patients opted for surgery rather than more drugs, and 9% were lost to follow. There was no association of any demographics, type of glaucoma, or baseline IOP with fill status. Our next question is, does this work at lowering IOP? And the IOP efficacy was done in 76 patients, 101 eyes. We used applanation or pneumotonometer in most of these patients. And in our population, it actually did not work that well. The mean change in IOP that we found was only minus 0.8 millimeters of mercury. Now, it's important to note that about 67% of our patients had a decrease in IOP, but 1/3, 33% actually had an increase in IOP. Paradoxically, the baseline IOP was fairly similar in all these groups, but if you can see that in the patients that it did decrease in, did a fairly good job, minus 3 millimeters in the patients it worked in. It is important to note this caveat that in our clinical practice, Netasudil was used as a last line treatment. These patients were already on 3.4 meds on average before we started this medicine. This is a graph which kind of emphasizes what I talked about. The graph shows the number of patients, and this is the percentage change in IOP. If the IOP decreased, that's 2/3 of our patients, most of them, it decreased pretty well. It's 20 to 30% or more than 30%. If it increased or did not change, which was 1/3 of the patients, it's kind of all over the map. And a few patients had considerably high pressure increase after starting this med. It's a paradoxical increase in IOP. What was the factors that determined this IOP response? And we looked at age, gender, race, baseline IOP, number of medications. We did not find an association of them falling in the two groups. What was different, although it's not statistically significant, is you can see there's a much higher proportion of secondary glaucomas. You see, these are complex post-op uveitic neovascular glaucomas in the group that showed an increase or no change. So the primary glaucomas do seem to respond better to Netasudil than maybe the secondary glaucomas. And this could be true of all medicines, not just Netasudil. Also important is the number of medications. In our cohort, Netasudil was always started as an adjunct therapy, not as a first-line therapy. So when only 1 or 2 medicines were used, it gave a pretty good response, -3 to -5, which is what we saw in the ROCKET study. When it was introduced as a 4th line or a 5th line drug, it didn't really work. And that, as we all know, is the same for all medicines, not just Ropressa. 48% of our patients continued the prescription and 52%, about half, discontinued. And the reason they got discontinued is mostly because of efficacy. The target IOP was not achieved, or there was paradoxical rise in IOP. Allergies or side effects were about 1/3 of the patients who discontinued this drug. So the other studies, and I'm only going to touch on one other study, is the fixed dose Netasudil latanoprost combination. They use the Mercury studies. Don't know how they find their acronyms. And this was done in patients with glaucoma, and this worked. The combination lowered IOP more than either of its constituent drugs, lowered the IOP about 2.5 millimeter mercury more than latanoprost alone. And the side effect profile, if you can see, was greater than either Netasudil or latanoprost. The staggering 59% of patients having conjunctival hyperemia, 15% with verticillata, and 11% with conjunctival hemorrhage. So how do I use Netasudil in clinic? And this is purely based on my own practice. This graph is from a meta-analysis by Van der Welk in 2005, which looked at many, many thousands of patients and RCTs and the efficacy of these drugs. Prostaglandin analogs are still king. I still use them first. Then I still think beta blockers work a little better than the Rho kinase inhibitors. And maybe they work better than the alpha agonists and the carbonic anhydrase inhibitors. But for dosing, the once daily dosage of the prostaglandin analogs, the beta blockers, and the Netasudil cannot be beaten. Then the timolol combinations, and then the 3 times daily dosing of brimonidine and dorzolamide. For ocular side effect profile, I think beta blockers are the best, and Netasudil is absolutely the worst drug in our armamentarium. For systemic side effects, however, Netasudil is excellent. It's at par right up there with the prostaglandin analogs, maybe slightly better than the topical carbonic anhydrase inhibitors. So in combination, Netosudil likely works with all classes. It should, right? Theoretically, except maybe the cholinergics. Patients on 4 times a day pilocarpine, I still have a decent number on that, or 3 times a day alpha agonists or carbonic anhydrase inhibitors can be offered a switch to once daily dosing. Adding Netosudil as a 4th-line medication is probably not much use, but adding any medicine as 4th-line medicine is probably not much use. Expense is the main barrier to filling the prescription in the United States, and side effects, lack of efficacy are the 2 main barriers to continuing treatment. I want to thank my collaborators, most of them at the University of Nebraska where I work, and this is my email. I'll be happy to take any questions.
Thank you, ma'am. A wonderful talk, very detailed. We'll come back to that. We'll go ahead with the next talk. Dr. Rajal Parikh, I'd like to invite you for giving your talk on principles of medical therapy in glaucoma.
Yeah, thank you. Is my voice clear?
Sure, sir. Sure, sir. Go ahead.
So I'll be talking about the principles of medical management of glaucoma. Now, we know that glaucoma is a chronic progressive optic neuropathy without a cure. And the objective of treatment is to stabilize the visual function. And mainly the vision must outlast the patient. Whatever the vision patient has, that we want to retain with reasonably good quality of life. Now, since angle closure glaucoma is very common in Indian scenario, the one questions we need to answer that does medical management of open angle glaucoma and angle closure glaucoma, open and angle is different, or and if at all, then what? And here the bottom line is that once the iridotomy is done, so we are not talking about before iridotomy. Iridotomy is the first line of treatment in angle closure, and after that, what are the difference of the objective of medical management? Now, when we talk about the medical management, first is establish the diagnosis. This is very important. Then the target pressure based on the patient's damage. Initiate the therapy and lower the IOP to target. Follow up to look for the progression or stability, and modify the management based on the target IOP if needed. If it's not needed, then it's very good. Now, the first is the establishes the diagnosis, because the whole objective is to diagnose the patient, and based on that we treat the patient. So if we miss the secondary cause and we assume that is open angle glaucoma, then we would be doing an injustice to the patient. So we have to determine whether the patient has glaucoma, what sort of glaucoma patient is, what is the underlying mechanism, whether it's primary or whether there's any secondary mechanism. Assess the risk factor. Exclude or confirm the alternative diagnosis. So secondary causes has to be excluded, and or if the patient has secondary causes, then we have to treat the secondary cause, because otherwise we'll be not able to control the disc damage. And plan the management strategy, the long-term strategy, because glaucoma is not a one-time event. It's a long chronic progressive optic neuropathy. It's just like the other chronic diseases, not curable, only we can control. So the management strategy is for the long term. Now, this is the diagnosis part. I'm not going to go in detail, but basically it has to be including all the various clinical examination. Slit lamp, gonioscopy. Gonioscopy is very important in Indian scenario. We cannot say that one eric is more than half is open angle. We cannot say that. Now, target IOP. Target IOP is based on the structural damage, functional damage based on perimetry, structural damage, optic disc examination. We can incorporate imaging. Baseline IOP is multiple IOP at which the damages happened, age, and presence of additional risk factor. Now, establishing the rate of progression is important, but the first time is little difficult, but that has to be kept in mind when we follow up the patient. Now, this is the EGS guideline, and it's very nicely mentioned that if the damage is minimal, if the lifespan is short, then we can go for the higher target. If the damage is very advanced, if the life expectancy is long, if the damage at the IOP occurred is in the low range, then we have to go for the lower target IOP. Now, corneal thickness is important. because especially its role in ocular hypertension and normal tension glaucoma has to be kept in mind, because if the patient doesn't have disc damage and if the corneal thickness is more, then it's just that Goldmann explanation is falsely measuring high, and that has to be kept in the mind. And second, normal tension glaucoma, before we send patient for the multiple systemic investigation, we must check the corneal thickness, because if cornea is thin, then what Goldmann is measuring is much less than what actually it is. So that the corneal thickness I do in every patient, but we must remember that in ocular hypertension and normal tension glaucoma is very important. Then we go to the initiation of therapy. Now, the aim of medical treatment is 24-hour IOP control with minimal medication, minimal local side effect, no systemic side effect, preferably, and user friendly. So once a day is always better than twice a day or 3 times a day. Now, there are various studies, and all the studies have shown in the various stage of glaucoma, from ocular hypertension to advanced glaucoma, lowering IOP is beneficial. The studies also have shown that IOP fluctuation is independent risk factor. So controlling the fluctuation also helps in controlling the disease worsening. So what are the factors we have to look for the selection of drug? Depends, of course, on the target IOP, but at the same time, we have to look for efficacy, compliance, safety, persistency, and in Indian scenario, affordability, because the insurance company is not going to pay. If you ask patient to use the drug which is going to cost him one meal, then he's not going to use the drop. So those things in Indian scenario has to kept in the mind. Now these are the various IOP lowering ability of the drugs. Prostaglandin is at the best, more than maximum, and alpha-2 agonist C inhibitors is around 20%. So if you want to look the objective that we have to choose the most powerful agent, then prostaglandin is the best drug, because it's once a day, has the highest IOP lowering ability, no or very minimal systemic side effect, little bit of local side effect, but overall its tolerability is much better, the adherence point of view is much better. So in ideal world, I usually start prostaglandin analog as my first line of drug in all my primary glaucomas. Now, if you look the various, and I'm not going to talk about, but most of the prostaglandin IOP lowering is more or less similar. Bimatoprost is 1 millimeter more, but it comes with the more local ocular side effects. So that has to be kept in the mind. Eyelid closure, punctal occlusion is 2 things we have to do in every patient. I have my staff telling every patient the same thing. Make sure the drug is working. So basically multiple IOP, usually after 2-3 weeks, I check the pressure. I call at least a couple of pressures, so we have a fair idea that IOP is the lower and it's reached target IOP or not. Now we start with monotherapy. If the target IOP is reached and no side effect, then we continue. If the target IOP is reached but patient has systemic or severe side effect, patient is not tolerable to the drug, then we shift. Now, when I start prostaglandin, usually I shift from one to other prostaglandin, because there are studies which shows that shifting helps. Now, if the target IOP is partially achieved, in that cases, I add another monotherapy. I don't go to the fixed combination from beginning. I have start another unfixed combination and look the IOP lowering ability of the second drug, and then go for the fixed combination. So these are the drug. We have to look the side effects. We must know the side effect of the drug. Hyperemia. If the hyperemia, if we given the drug once a day, one eye, and patient gets severe hyperemia or severe lengthening of eyelashes, is going to be very cosmetically troubling to the patient. So we have to keep that thing in the mind. Periodically, as I said, that is a chronic progressive disease. Periodically, intraocular pressure, visual field, optic disc, quality of life, all these things has to be measured, looked for. We should not go only by the IOP. To conclude, medical management is the first line and the major, because if you look the studies, majority surveys, more than 85% of the patients are on medical treatment. So medical management is the first line. IOP and IOP fluctuation both are independent and both are important risk factor. We must target IOP is not the fixed, but it's a dynamic process, but we must calculate and look into the follow-up visits. Prostaglandin analog is the preferred as first line of therapy, and we must know the side effect of medications, because those things in follow-up visits would be important, because sometimes patient may forget to tell you that is asthmatic, and follow-up visit, you are given beta blocker, this asthma may worsen. So you must know the side effect of medication and accordingly change the medication. Thank you.
Thank you, sir. Very informative talk and very lucid also. Now we'll go into the discussion. I'd like to ask Dr. Aditya my first question, like how often do you do fields for a new patient glaucoma?
Yeah, new patient, basically a lot of logistic issues come. We try to do the first field and then again, I try to get a second field at least done within 6 months. But many a times patients may not want to do or other things, but I would prefer to have at least 2 fields within the first 6 months. And depending on how the glaucoma is, if it's mild glaucoma, once a year I would prefer to do a fields. And if it is more advanced, 6 monthly, I would prefer to.
And you use these first 2 fields as the baseline and then base your decision on the further.
If both the fields are done well, but many a times that is not the thing. Yeah. Sometimes we, if a field is not done well, we call again a day or 2 later and try to get it done. And in that situation, we can do it without extra cost to the patient. Because one of the main problems is the cost to the patient for the fields. So that is what we try to do. If the field is done very, quality of the field is very bad at the first fields.
Okay. And do you do fields in a dilated pupil stage, or do you? How do you?
Yeah, mostly it is done in dilated state because what happens after assessing the person, the fundus evaluation, then if you see there is any need for doing a field. So most patients get it is done dilated, but sometimes it may not be done dilated in situations like when there is a narrow angle, we assess the patient without dilatation prior and we see some disc changes and advise a field, then it might be done undilated.
You usually use the Humphrey field, I suppose, because all
yes,
your...
yeah. Yes.
Okay. Any other questions to Dr. Aditya? We'd like to discuss some aspects.
Aditya, just one question from my side. What do you think of the newer perimeters that are in the market? You know, everybody says that they can do a field using a...
Yeah, there are a lot of new things, very interesting, some of them, but I think they would need some more validation, I guess, before we can jump into them, because that is what I feel. And because the perimeter, what we are using, the Humphrey, is at least we are able to follow up. This is one very important thing. With a new thing, unless we know how the thing goes, I think initially for our patients, I think we should stick to Humphrey. That is what my feeling is.
Yeah, so either a Humphrey or a good quality octopus or Medmon field, which has a databases with which you can do follow-up, because ultimately we require the visual fields for follow-up much more than we do for diagnosis.
That is the most important thing.
Dr. Sai, your hand is up. You wanted to ask?
I have a question for Dr. Deepta. Clinically, do you see the rho kinase corneas to be better than the carbonic anhydrase in corneas?
That's a good question. And yeah, I see the verticillata sometimes, but they don't seem to bother the patients unless they have red eye. The big issue with Ropressa seems to be the red eye. People, you know, they start with it. Sometimes it's so bad that they stop it within a week. Sometimes after a month or 2, it starts with a little redness and then it becomes redder and redder. You do see some corneal changes, epithelial changes and all, but they're not bad. The carbonic anhydrase inhibitors, I mean, personally, I use them in Fuchs and all. The only place I don't use them is in very, you know, 3rd or 4th graft kind of patients who've already been surgery, because a high pressure is worse for the eye than what the carbonic anhydrase inhibitor will do. So, you know, that will take away more of the endothelium if the pressure stays high rather than what it can do. So, and, you know, surgery is bad for the endothelium too in these patients. So if I can control them medically with a carbonic anhydrase inhibitor, that is better than them going blind. But yeah, they have different effects. And It's mostly red eye. Red eye is bad.
Yeah, interestingly, a lot of cornea people are using nitazoxanide these days for reducing their corneal edema, isn't it?
That's why I asked that question.
Yeah.
Cornea,
I heard about that, but the other side effects are so bad. So you have severe red eye, but no corneal edema. So sorry.
Not very good for the ocular surface, I reckon.
I tried reading about this, and there were a few case reports where they say the endothelium actually count comes down with treatment. So I don't know what's happening.
In the Journal of Cornea, there has been at least, from January, July, last month, there have been publications of case reports. The last case report I read was on 3 cases, one of ideochondral endothelial syndrome and 2 cases of graft failures, which were successfully treated apparently with nitazoxanide once at night dosage for a period of approximately 1 month. And there have been some good pentacam pictures also. So that's what I'm saying. The cornea people are in fact asking me, how good is this drug?
There doesn't seem to be a whole lot of theoretical basis for this. It's saying something about phospholipids and other stuff. But yeah, we'll see if it lasts the whole thing.
Regarding nitazoxanide, like what is its role in angle closure disease? Like we have lots of angle closure glaucomas. Maybe you do the PI and the IOP is still high. Do you see a role of ROCK kinase inhibitors in that question?
Yeah, I mean, that's again a good question. Also, things such as when the conventional outflow is completely closed, like a neovascular patient. If the conventional outflow is completely closed, will it work? And the answer is still vague on it. If some of it is open, then I think it should work. If it's completely zipped closed, probably not. The other question rises, if you already have a tube which is not working so well or a trap, is all the flow being diverted there versus the conventional outflow? So will the conventional outflow work then? Pilocarpine does tend to work in these people with, mildly working tube. So maybe it will. This is a good question. I don't know the answer to that.
Still worth a try.
Try it, and if it works, great. And that's kind of how everything with nitazoxanide works. We're using it as a last line, so at least third line. I'm not using it as first or second line at least. So.
Maybe you had a comment?
Yeah, can I just ask a quick question to, again, Dr. Deepta? It's about the redness and the IOP relation. I don't know if I missed it. Is the redness associated with the heightened IOP? Because we tend to see that with alpha-GAN.
Yes, absolutely. And that's a very good question. And in our study, we did not find that. But in alpha-GAN, the idea is maybe there's some trabeculitis going on, and there's been paradoxical uveitic syndromes too with brimonidine. So maybe that's what's going on with paradoxical rise in IOP. But we didn't really find a big correlation. And that could be because so many of our patients left the drug before for other reasons, not just redness. So it was kind of challenging in a retrospective study to figure it out. Be a great prospective study design if we could. And I suspect that's true anecdotally. When the pressure goes up, they also have red eye, just looking at, but and anecdotes will only take us so far.
Regarding the decrease in the episcleral venous pressure, is it because of the relaxation of the muscles of the vessels, or is there any other?
Some vasodilation issue. In the past, the non-selective alpha agonist propine and epinephrine and all also did that, but they're not used anymore. Carol Torres, who was my mentor, said apraclonidine did that, but again, it's not a drug that we use. But the EVP data is fairly robust in animals, but it's not that robust in humans. There's only one study, there hasn't been more, and in any case, EVP measurement is so challenging and so fraught with errors that it's tough to draw conclusions.
Yeah, okay. Are there any more questions? Or we'll go ahead with the next session.
Yeah, thank you, Dr. Abhilash. So we'll go ahead with the next session in the interest of time.
Thank you.
So it's a pleasure to introduce the last two speakers in this session. The first is Dr. Bhaskar, a close friend and Deputy Director of Glaucoma Services at Shankar Nethralaya. He was formerly clinician scientist at SERI in Singapore. He did his DO and DNB at Chennai at Shankar Nethralaya and his PhD from NUS. He is an excellent clinician and has managed all sorts of complex disease. He actively academically mentors postgraduates, optometrists, and PhD students in ophthalmology. He's extensively published, and he's also got a few innovations to his name, none of which he has put here. And he'll be speaking to us a little later on lasers. The last speaker in the session is Dr. A.B. Jacob, who graduated from CMC Velo and actually was the driving force behind the Velo Eye Survey. He did his ophthalmology training from CMC, Birmingham and Midland Eye Center, Yorkshire Deanery. He did his specialist registrar training at St. Paul's Unit and the Royal Liverpool University Hospital. He's the clinical lead at the Southampton Eye Hospital, and he has taught at least 2 people on this panel, and I can attest to the fact that he's an excellent and very patient teacher and an excellent surgical teacher too. So it's a pleasure to have you here, Eddie. Bhaskar, can I invite you to give your talk on lasers?
Can you hear me?
Yeah, we can hear you, Bhaskar.
Yeah. I'd like to thank KSOS and Cochin Ophthalmic Club and Dr. Ronnie for inviting me for this refresher course on glaucoma. My topic is on lasers in glaucoma. To talk about laser tissue interaction in ophthalmology, we have 2 mechanisms: photocoagulation or thermal reaction and photodisruption, which are used for our advantage. Sorry. Okay. So in the first photocoagulation, laser energy is built up to release heat and cause either photocoagulation or a stretch of the tissue. And like argon lasers or micropulse lasers or diode lasers. And in terms of disruption, high concentration laser energy is used to produce plasma and at the expansion pressure waves disrupt the tissue, like in the Nd:YAG laser, and which like in the iridotomy. In this 10 minutes, I'll be able to cover those lasers which we use routinely in the outpatient, like the iridotomy, laser trabeculoplasty, iridoplasty, cyclophotocoagulation, and some procedures like argon laser suture lysis. Those lasers which are used with the surgical filtering procedures, I'm not going to cover in this. Going to indications of laser iridotomy, angle closure glaucoma and combined mechanism glaucoma we know very well. Pupillary block after cataract surgery, nanophthalmus, and incomplete surgical iridotomy are some of the other indications, with a whole lot of other indications also, like uveitic glaucoma, etc. Contraindication for laser iridotomy is more relative. Severe corneal diseases, flat anterior chamber, severe uveitic conditions are difficult to use iridotomy with. In the technique, the commonly used laser is the Nd:YAG laser, photodisruptive one, more for practical reasons than any in brown arets. In fact, the recommendation is a sequential laser with argon and then subsequently Nd:YAG laser in brown arets. The combined technique is with basically it is to stretch and coagulate initially and then use the Nd:YAG laser to penetrate the iris. To prepare, people use myotics, continue the anti-glaucoma medications. Preoperative brimonidine is routinely used nowadays to lower intraocular pressure spike, usually to be used at least 30 minutes before the procedure. Inform the patient about dysphotopsia and other minor complications. It's always useful in practice to avoid surprises from the patients later. Good to use the Abraham and Weiss lens or Weiss lens, where there is a convex button to increase the magnification. Direct penetration technique is used in Nd:YAG with a sequential is usually advised in brown irides. And in the Chinese eyes, we used to do a lot of this in brown irides, but in Indian context, for practical purposes, we are using Nd:YAG. And the advantages of the contact lens is that it concentrates the energy at the iris level. Lens acts as a heat sink, and it decreases corneal burn and acts as a speculum, and of course provides magnification. Talk about the corneal burn. Laser iridotomy per se seems to be not determines the changes in the endothelium. Previous acute angle closure, pigmented irides, endothelial disease, diabetes, laser type, delivery quantity, all these things determine the corneal problems, as you can see in the localized edema. In some patients, even requiring corneal PKs over time. These are the various settings. In the organ, we use 400 to 800 milliwatts power at 50 to 100 micron size in 50 milliseconds to stretch the iris to 80% of the depth, and then use 2 to 3 millijoules usually power to disrupt the 20%. Usually a 150 micron minimum opening is what is required to take care of the pupillary block. Usually avoid the arcus and blood vessels. Iris crypts are used if they are there. Avoid 3 and 9 o'clock to avoid bleeding. Control bleed with pressure with lens if at all it happens, more so with the Nd:YAG lasers. 40% patients used to have, and now with improved versions of the lasers, this bleeding is much less. Position of the LPI is controversial, but temporal LPI tend to avoid dysphotopsia. There are some studies on that. Beyond the mid-periphery, it should be done to avoid sphincter distortions and lens damage. And you can see there were studies on the dysphotopsia. Base prism effect of the tear film under the upper lid was attributed to this, and temporal LPIs seem to be safe to avoid these visual symptoms. This was done in an RCT. Again, size of the LPI, 150 to 200 microns is optimal. Large PIs are generally avoided to avoid protect the zonules. Clear visualization of the anterior capsule or deepening of the anterior chamber and clear fundal glow through the PI are criteria for success. And post-operatively, IOP check is done 1 to 2 hours with steroids to be continued for 5 to 7 days. Follow-up care if IOP spikes are noted. And follow-up gonioscopy for eliciting mechanisms, or sometimes they use anti-segment OCT as well to follow up these patients, especially in plateau iris kind of conditions. And here is a study on angle width, which is widened till 6 months, and then it tends to increase because of lens changes. This is in a bunch of Chinese population, so we don't know what could be the change that happens. So the angle tends to narrow over time. So it is important to do follow-up gonioscopy in these patients. And it is because of the lens vault also increasing in size. So there is a push of the lens coming forward, not just the size of the lens that is increasing after LPI. These are the various complications, not going into the details, but with improved lasers, we tend to see less and less of these. And take care when you are doing a LPI in a pupil block for uveitis. There are chances of erythema and inflammation, so steroid cover is necessary. These are some of the studies and efficacy in asymptomatic PACS. I think Dr. Arun has covered this, but generally LPI gives you 50% protection over 5 years in terms of progression to the next stage. It depends on the definition again. And similar trials, one of that is ZAP trial, which is already published, and another trial analysis from Singapore will be published soon. Over a period of time, some retrospective studies have identified risk factors of progression after LPI, like age, peripheral anti-synechiae, narrowed anterior chamber angle to begin with, not doing cataract surgery early. These are risks for progression after LPI. And coming on to laser trabeculoplasty, some of the facts about it is that it reduces intraocular pressure in glaucoma patients by increasing the outflow facility, and it works at 4 to 6 weeks time. There are two theories, mechanical theory and biological effects due to altered synthesis of glycosaminoglycans. And all forms of open angle glaucoma and some of the pseudophakic and inflammatory glaucomas are where trabeculoplasty is done, but the later respond poorly to the trabeculoplasty. Preoperatively, one need to evaluate the corneal clarity, IOP measurements, and similar preoperative measures like what we use for iridotomy is used. A special trabeculoplasty lens is used in this case. I'll talk only about the selective laser iridoplasty because that's being used more often. They use the argon or the diode or even micropulse laser nowadays. 600 to 1000 milliwatts power is used, and the 400 micron spot size, which is standard, is being used now. And junction of the pigmented and non-pigmented trabecular meshwork is treated. 60 to 80 spots for 360 degrees is recommended now, and repeat treatments at 3 months is usually done. 3 spot space between laser spots in gold argon laser and 1 spot space for SLT is used. As you can see that in the older laser, bubbles like this can cause excessive treatment. But in the SLT, you can see that SLT or the micropulse laser which is used. So for the selective trabeculoplasty, minimal damage to the trabeculum is occurring, and so repeat SLTs are easy. Postoperative management is similar except that excess use of steroids is avoided and NSAIDs are used for only 3 days because the inflammation itself triggers the increase in outflow facility, and measure intraocular pressure at 4 to 6 weeks for efficacy. Long-term worsening of glaucoma, acute pressure elevation, uveitis are some of the complications. And long-term worsening of glaucoma is something which happens when patients get the trabeculoplasty and then go with the belief that it controls the intraocular pressure. So it's important for these patients to be brought back and followed up regularly. This is something which we see in our clinics very often. This is the major trial result that is published recently in the Lancet. 20 to 25% drop in trabeculoplasty compared to medications. 74.2% required no drops at 36 months. And they had better quality of life and less number of postoperative visits. And so the study recommends selective laser trabeculoplasty should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension. Of course, we need more studies, more RCTs in our context, and to see if this is true. And of course, we need to look at the cost effectiveness as well. Coming on to iridoplasty, unresponsive angle closure glaucoma and various other indications are listed here, especially plateau iris syndrome. And the Hong Kong group has done iridoplasty in acute angle closures as well. And that is the only RCT. And so that is something which is a bit tricky. However, we found that in a patient with medically unresponsive to acute angle closure, iridoplasty can actually open up, and we may be able to do a peripheral iridotomy in those cases. The settings, basically 500 micron spot size, larger spot size, lesser energy will stretch the iris and opens up the angle. This is a plateau iris case. After peripheral iridotomy, it didn't open. With the iridoplasty, you can see it is open. However, one of the RCTs done in Singapore shows that iridoplasty did not control the intraocular pressure longer period compared to the medications, and even had corneal endothelial cell count loss. Now coming on to cyclophotocoagulation, we have various lasers available now, diode, micropulse, and to cover the topic into cyclophotocoagulation as well. It drops the intraocular pressure to 30 to 45%, but it's fraught with complications, as we know. And in failed prior filtration surgeries, high-risk filtration surgery failure, and eyes with poor visual acuity. These are the patients where we do this cyclophotocoagulation, but with the advent of micropulse laser, the indications are changing, and even primary open angle glaucomas as primary treatment, people are doing it. Of course, we need more evidence to take that leap of faith, but I hope that more evidence comes and we will be able to have a better practice with these lasers. And to talk about the G probe, it is a 600 micron quartz fiber tip with a cable length of 2 meters and usually meant for single use, even though in the Indian context we tend to use it more. 4 to 5 usage seems to be fine with the laser energy coming from the tip. And this is a busy slide showing the various probes. It started with this kind of probe, the G probe, and the settings, you can see that 18 to 20 spots for 270 degrees is usually recommended, with the repeat maybe more. And this is the Cyclo G6 for micropulse. Usually the way in which we treat is different. These are spots, and here it's a sweep of the probe across the superior and inferior fornices. And this is usually 360 degree treatment with the micropulse, and 100 to 360 seconds are used. And for the repeat treatments, 3000 milliwatts power even are used. And it seems that these two lasers are good to go repeat with a micropulse laser, even 3 times being used for patients to achieve intraocular pressure control. Usually with the diode cyclophotocoagulation, 1.5 times is what is used. That's about the settings again. And to cover the cyclophotocoagulation topic, endocyclophotocoagulation, when they use it for 270 to 360 degrees, usually in a patient intraocularly when they do the cataract surgery, and a 0.2 watts setting is used in a continuous wave mode. Of course, we are worried about the complications of CPC like phthisis bulbi and sympathetic ophthalmia, even though they are very rare. Commonly, we see increased inflammation and drop in visual acuity we need to be taken care of. Finally, looking at one of the lasers we use commonly in patients with post-surgery to cut the sutures. We use 50 to 100 milliwatts power, 50 micron size, 50 to 200 milliseconds, and that's a Mandelbrot lens we use to give pressure on the conjunctiva to blanch the vessels and do the procedure. That'll be the final slide, I guess. And there you can go with 2-3 spots, we will be able to open up the suture. With the increasing number of lasers and the technology improving, we need to keep updating. More so, we need more evidence. And with more evidence, we'll be able to practice better lasers in our practice. Thank you for listening.
Thank you, Bhaskar. We'll move to the last presentation. I'd request AB to speak to us about trabeculectomy, and then we have some time for discussion.
Good morning, everyone. Thank you, Sai, Gopal, and Ronnie for having me. Missed Cochin last year, but hey ho, here we go. I'm going to talk to you today about trabeculectomy, its indications, and my pre-op and post-op management regimes. It's by no means a comprehensive talk, and I don't have any videos in it as well. Why isn't it moving? Yeah. People have covered the pathophysiology of glaucomatous optic neuropathy. It's multifactorial, but the important thing that we have to understand is that the only thing that we really can have some sort of control over is the intraocular pressures. Hence, surgery is important. Now, we'd all like to have a trabeculectomy where the bleb is looking like this, but this is not a trabeculectomy actually. So when Keynes came up with the trabeculectomy in 1968, it was a huge development on the pre-existing technique of a full thickness sclerostomy. The good thing about practicing in the UK is that you tend to see some of these old historic operations once in a while. I guess not many are surviving now. But this should be the appearance of a trabeculectomy a few weeks in, and we would like to achieve this result most of the time. And for this, we have to concentrate on the basics. And a very good stop there would be to look at the Pencor safe surgical system. Now, there are a lot of potential trabeculectomy rivals. And this slide is deliberately crowded for a reason, because it is a crowded field. And a lot of you will come under pressure to be doing some of these procedures. But the important thing that you must realize is that this whole bunch of operations are competing for just one bunch of one small subsection of glaucoma, and that is the open angle glaucomas. If you have only one surgery to learn to treat glaucoma, you have to do a trabeculectomy. And that will soon be the no man's land, because once people start getting their hands dirty with the fancy technology and the more expensive technology, you will find that people tend to get less experience with the trabeculectomy operation, as it seemed to happen when latanoprost arrived on the scene. Now, this here is a case of the Zen implant, and you can see it nicely sitting there under the conjunctiva with a nice bleb. This lady had multiple vitreoretinal procedures, and you can see the Zen in the same lady in the angle as well. This scan is of somebody else, and you can see the Zen sitting in the anterior chamber nicely, slightly anterior to the trabecular meshwork, and that's where we'd like to place the Zen these days. Similarly, here is the iStent, which is the other technology that is in direct competition with trabeculectomy operations. A new kid on the block is the Omni surgical system, which tends to do a canaloplasty for you, or even a GAT for you, if you so wish. But that is not relevant to the talk. The important thing is that we do have a crowded field, and it's very important to understand what each operation does for you. And the trabeculectomy sits here as a trabeculoscleral bypass. There are technologies that give you the same effect, but this is the best little operation that has stood the test of time. Indications are fairly straightforward, but the most important thing to understand is that failure of medical management may be due to all sorts of causes. Like, for example, in the Indian situation, cost is a major factor, because if a patient can't be compliant with his or her treatment, that is a failure of medical management. In our situation, where it is socialized medicine, where the patient doesn't really pay for the drug, it is actual failure or a lack of tolerance. Now, a trabeculectomy can be done in all sorts of situations, like following VR surgery. Like in this case, oil doesn't have to sit nice and clean for anyone to make a diagnosis. Oil can be very subtle. Okay, here it is as some frog spawn, and that's where I put the trabeculectomy, because you don't want it to be in the area where the trabeculectomy, you don't want the trabeculectomy to be in the 90-degree area where the oil could be floating up to. Contraindications are actually relative. I sometimes do even 3 trabeculectomies for a patient. The VR surgeons have actually become my friends these days after 23 and 25 gauge VR surgery has come. Neovascular glaucoma, you can still do a trabeculectomy provided everything is under control. And in some cases of uveitic glaucoma, there may be a role for doing a trabeculectomy as well. There are pitfalls. Here is one of mine. It's a very current one. This was a picture of this chap a couple of days ago. He is someone who had a Zen about a year ago. I needled him about a couple of months ago, and then finally did a trab after both of them had failed. But fact remains that this chap had 3 doses of mitomycin, and now his conjunctiva is a bit reluctant to provide resistance to the bleb. So he is going through a phase of hypertony. So you need to be prepared to look at the various little nuances that could creep up in your practice and surprise you. This is the Optos image. As far as pre-op management is concerned, the important thing that we must all be very aware of is that about 60% of glaucoma patients do have some version of ocular surface disease. Preservatives cause significant cell damage, and they also prime the conjunctiva to react in such a way that your trabeculectomy can fail. Drug-induced orbitopathy is a serious problem, especially with patients having been on prostaglandins for a very long time. it makes access very difficult. Quite often, you need a nice peribulbar block to bring the eye up to have access to the superior conjunctiva. Therefore, when you talk to a patient prior to surgery, you need to go through the risks and benefits. You have to explore all the alternatives because they would have read the latest news release from the eye stent people that this is the cure for glaucoma. So you have to have a lot of discussion with the patient, and you have to condition the patient. Part of the conditioning that I tend to use is I also put them on preservative-free drops as much as possible. And the other thing is that I get them to get the message that this is not a simple, straightforward operation. This is no cataract operation. You're not going to see much better after this. A banking concept I have brought into the equation here, that is know your customer. It is not rare when you find out after you've operated on some patient that this fellow takes one hell of an effort to stand up. Like, some people who are using crutches and things like that, they put a lot of stress on your trabeculectomy, and don't be surprised if they end up going hypotonic because your suturing is not good enough. Preoperative Diamox is useful provided you can control the side effects, and preoperative steroid may have a role as an anti-inflammatory and also to downregulate the activity of TGF-beta. Like I did mention earlier, I love peribulbar, especially in these deep sunken eyes with no superior sulcus. Intraoperative management, as I mentioned before, good exposure is very important. Need to respect the conjunctiva, need to listen to Thomas Dodge's talk on forceps and how to use the appropriate forceps. I tend to inject my mitomycin these days. This is a fallout of having used mitomycin as an injectable during Zen surgery. I tend to do my cautery minimally, pre-place the sutures, and very important message, use an anterior chamber maintainer in vitrectomized eyes. Otherwise, these eyes tend to collapse during surgery and it's a pain. And closure of the conjunctiva is also very important because you've got to be meticulous. And if you don't get the edge to edge, there are chances of getting a prolapse of subtenonous tissue. And these are the awful looking avascular blebs that you see once in a while. Post-operative management is fairly straightforward. I use preservative-free drops and use cycloplegia in the case of angle closures or small eyes. But start off with the regime of 2-hourly dexamethasone, which I taper over 4 to 6 months if there is no intraocular pressure response due to the steroid. Post-operative management, again, see them on day 1 and then weekly review for the next 4 weeks and then bi-weekly, and I start stretching them out. I rarely use subconjunctival steroid. I tend to give them more drops rather than subconjunctival steroid, unless I'm fairly sure that they're not getting the drops in. If top-up of anti-mitotic is required, I take them into theater for MMC. I rarely use 5FU these days and occasionally use Avastin more often in the neovascular glaucomas, and I do perform them in theater. Removal of releasable stitches, definitely not in the first week. Have had several instances of enthusiastic registrars pulling out the stitches on day 1 and week 1 and then dealing with the hypotonia after that. And the other thing I insist on doing is to remove or cut all the releasables before I stop drops and get them out of sight. In a JIS, postoperative management, high intraocular pressures, I deal with suture removal, massage, modifying steroids, and topping up mitomycin C. Encystments can be thick and be associated with high intraocular pressures. I try and massage my way out of it, but if need be, needling with mitomycin. Low intraocular pressures are the bane of your life. Especially we did have a small phase where our concentration of mitomycin was a slight issue and did have a couple of hypotonous eyes. I tend to sit on them as much as possible unless they go to a maculopathy. And if it's a maculopathy, I take them back into theater. If it's a choroidal effusion, I try and give it as much time as possible to settle before I go in for a choroidal drainage. So that is a sort of bleb I aim for. I tend not to incise my cornea to bury my releasable stitches. I tend to leave them under just an epithelial scratch. Sometimes they come out like this. Useful thing is it's easy to remove, and more importantly, no one has an excuse to say that I couldn't get at the stitch. That's basically it. That's a photograph of Southampton Docks with the 3 queens in there. That is QE1, QE2, and the Queen Mary. Thank you very much.
Thank you, Abhi, for covering some of the issues with trabeculectomy so elegantly. You did say once that you even have done 3 trabeculectomies in an eye. So how do you go planning your first trabeculectomy? Do you actually plan for the future? And most glaucoma surgeons know things are not going to work.
Yes. See, the classic Moorfields training is for a 90-degree total annihilation of the conjunctiva trabeculectomy. Okay. So after that, there's not much scope for doing a second one. I try and drive this message into them saying that your trabeculectomy is not going to last forever. You need to give the second person who comes along, I'll retire and go, second person who comes along a chance to do something that they can get away with rather than sticking in a tube. Because Moorfields, it depends on the flavor of the month. Whoever is the clinical director of the place, he runs the show. So if it is Keith Barton, it is tube for anyone who comes anywhere near Moorfields. So that is the basic training in this place. I tend to put my trap to one side or other so that there is a definite opportunity for a second trap. That's one. 2 is after Zen came, I tend to drift towards the temporal aspect. So in case you want to do a Zen at a later date, there's an opportunity to stick it in to the nasal conjunctiva. So yeah, I always tend to keep my dissection minimal, at least at the limbal edge.
Yeah, you also spoke about, asking history about, you observe how a patient gets up from his chair or whatever it is. So any sort of Valsalva maneuver postoperatively can be a nightmare for us. And is that the reason why you specifically mentioned that?
Yes, you have to understand, you have to know your patient. I borrowed the know your customer from the Indian banks, basically because of that. See, many a times that you get caught out. And that is when you find that this guy is actually struggling to get up off a chair. Or there's an old lady who potters around her garden pulling out weeds. Simple little things that we tend not to really get into our discussion in the preoperative sort of phase. One thing that gobsmacked me was one chap who was slightly demented. He was with it, but I realized how badly demented he was when he came for his 5th or 6th visit with the same shirt on. Okay, so even though we see these patients regularly, we tend to miss these little fine details. And then you wonder, are the drops going in? What's happening with these patients? You just don't have a clue.
Dr. Sai, you wanted to say something? You're muted.
Yeah. I have two comments regarding the laser talk from Dr. Bhaskaran. Two very unique clinical situations. One is these post-VR secondary glaucomas, which we see quite often. You do multiple PIs, they get closed again and again. Do you think we need to do larger ones? Would that really make a difference? That is the first comment. The second comment is the PIs in eyes with pseudo exfoliation. It has been my clinical observation that the eyes which have undergone the PIs definitely have more zonal weakness on table when you take them up for cataract surgery compared to the eyes which do not have a PI. There may be a bias there because the PXF eyes with shallow chambers would probably have more zonal weakness anyway. But what is your experience regarding these two clinical situations connected to the YAG PI?
Oscar, you're muted. Do you want to take that?
I think his video is stuck.
Yeah. Dr. Deepta, you wanted to make a comment?
Yes. So about exfoliation, actually, that is a very astute observation. One of the prognostic factors for zonular weakness is AC depth. So people with lower AC depth, the AC depth is narrow because the lenses move forward. So that's the hypothesis. So they get the PI and this is, but I do like doing PIs before dilating on table in the pseudo exfoliation people, just because you never know what's in the back sometimes. And in general, I like to do PIs rather than dilate on table. But yes, there is an association. I believe, I forget the exact number, but I think it was 2.3 or something. And that was a prognostic factor for zonular weakness on table. So.
Okay.
Yeah, Dr.
Sorry, there was a funny situation. My dog ate the Wi-Fi box to replace it.
That is amazing.
Very unusual situation is your VR surgery cases. I think maybe it's to do with the inflammation part. So I tend to do a sequential laser in these cases, and it might work. That may be one option. But if it's an incomplete iridectomy, which you are trying to do, I think sometimes we may have to keep repeating. We do have that situation. Yes, maybe with more steroid cover, it's a possibility that it may be remained by patent. And the second situation is like a chicken or the egg situation, like what you guys are talking about. Probably these guys have more zonal weakness to begin with, and then you are going to do the PI and you are seeing that, yes, we do have these narrow angle patients with pseudo exfoliation, and more often the zonules are weak, something like a loose lens syndrome that happens in these patients. Yeah.
Dr. Ebi, you wanted to say something?
Yeah, I did want to just highlight that these lenses are, these angles are narrow because the zonules are weak, especially the anterior zonules. So there's nothing holding it back, and that's why it's coming out there. And the other important thing that I tend to follow if I am planning on cataract surgery on anybody, angle closure, pseudo exfoliation, anything, is to have a low threshold for the surgery. So at the earliest sign of a symptom, I try and go in because I'd rather not do that PI and wing it till I do the cataract operation. Because if you get caught out during cataract surgery, you have a lot more questions to answer. So you just got to think of being safe as well. I mean, Sai, you're an excellent surgeon from what I hear. Yeah. Apparently, one of my cousins have had surgery with you. Anyway, you want to make that cataract surgery the best outcome possible, and you don't want to increase the risk. And it's the same thing with angle closures also. If I have a narrow angle which has got a sort of a early cataract, I try and wing it till I get to that cataract surgery, because then I can go in, I can look at the angle. See, I do a lot of viscogonioplasty. It was initially, I started it off as a sort of sort of a game to get ready for the angle surgery, but it comes in very handy looking into the angle while you're doing cataract surgery. It just opens up your eyes one hell of a lot.
So, Abhi, now that the light trial results are out, have you increased the number of facilities? Do you see the similar sort of success rates among your patients?
See, the light trial, I mean, I did the NIHR review for that. The light trial and all those things work in that sort of situations. Okay, so if you have a whole system geared to having a patient, and then you can decide, all right, this person is having laser, he will have it today or tomorrow, it's fine. What I do is I put the patient on a waiting list. I don't know when he is going to get the bloody laser. Okay, so in that sort of a situation, I'm not covered till he has a laser. So I start him on drops.
So you're saying practically it's difficult to follow what they do in the UK. In India, it's probably easier because we can probably...
In India, you might find it a little more easier. Having said that, one of the things that have come out of the newer research is that the SLT might be engaging the anterior trabecular meshwork cells, which are lying dormant and not really being used. So if you go and burn up the trabecular meshwork cells in the functional part of the trabecular meshwork, the theory is that the SLT could activate whatever remodeling and some migration of these cells into the posterior part, therefore it works a little bit better. And that is the sort of theory that we used to work with for non-penetrating, because again, we were going into the non-functional part of the trap. So yeah, it's all sort of adding up.
Sai, did you have anything to add? You have a...
No. I just wanted to ask Dr. Abhi whether in his practice, mitomycin is a strict no-no in high myopes, or do you have some sort of graded approach in high myopia?
We tend to use a sledgehammer for cracking the nut. We use mitomycin all the time. Partly because it is part of the NICE guideline. And the last thing you want to do is to do a trap and find that it scars up quickly. So you have to use something. Then the question is, what's the strength you will use? We are already using 0.2. So, you know, it sort of works. We do get caught out once in a while. The myopes are the ones who classically go into maculopathy. And it's never pleasant, but, you know, it's not too bad. It's not, you get the odd one, but that's part of being a glaucoma surgeon. You can do the most perfect operation. And
I think TG, what is your take on that?
Actually, I use mito on everybody. Only thing is when they're younger, and I use mito injection. So I use 0.1 ml as a subconjunctival. And myopes and younger individuals, I cut down on POP, I mean, one-fourth of it. The tubercle syringe, I just cut down. That's more of an emotional thing than with any proof. I don't see much of a difference. I use mito on everybody.
Yeah, so I also cheat a little bit like what TG said. What I might do is I might just, before I put in the mitomycin, I might just stick in a little bit of lignocaine. So the whole thing actually is diluted when it goes in. Or cheat on the thing and just take out 0.1 of that whatever on the insulin syringe. Yeah, just...
Maybe I do something else also.
You're on public domain, Abhi.
Yeah.
Yeah, I know, but that's fine. That's fine. That's fine.
I do something else also.
What else?
That is, I send in the mito 0.1 ml and I chase it in with BSS on all my cases to spread it out with a hydrodissection syringe through the same puncture wound. So it spreads out.
Yep.
So that does dilution for me, all cases.
Yeah, ultimately, we all have to do whatever it takes to make it as safe as possible for our customer.
Do what works in your hands.
Yeah, and what works in your hands.
Okay, so I think we are almost half an hour over time, and if there are no last final urgent questions, I'd like to thank all the speakers and the moderators for this interesting session. We had speakers from 3 continents, and both Dr. Deepta, Ebi, and Arun have been struggling with difficult time zone issues. Thank you all for a very entertaining and informative session. Again, thank Cochin Ophthalmic Club for the opportunity, and Dr. Sai and Dr. Gopal for the confidence. So thank you, and hope to see you all in person sometime soon.
Thank you, everyone. Bye-bye.
Thank you, everyone.
Thank you very
Thanks.
much.
Look forward to the next
Thank
meeting.
you.
Thank you. Thank you so much.
Yes.
Thank you.